adolescents, adults, couples, and families. On May of 2020, Dr. Tamargo was infected by COVID-19. She and her family moved to New York City in October 2020 to receive post-COVID care after her 5th hospitalization. Dr. Tamargo has participated in numerous long COVID studies at Mount Sinai Hospital, Yale, Massachusetts General Hospital. She is an advocate and expert founder of Mass Together America. Now we will bring Robbie to the stage. Thank you, Dr. Robbie.
Hello. Apparently Alexa's decided she would like to talk with me. Okay, how's that? Can you see my screen okay?
No, we don't see your screen yet.
Okay.
No worries.
We see you very well, but not your
Okay.
screen yet.
I'm not doing something correct. Okay, let's see. No. I'm sorry.
It's okay, take your time.
Don't share screen. Is it sharing my screen yet?
No.
There's a green button on the Zoom to share screen. Did you select that?
Yes, I have.
Okay. Are you able to select your slideshow from the Zoom menu?
I will try that. Maybe that's slideshow. Can you see it now?
Not yet.
Okay, I can see myself now, but I don't see my slideshow. So, oh gosh. Trying to go back to the menu.
Thanks everyone for your patience. We'll be getting started with the presentation shortly. How about now?
Not yet.
Okay.
Perhaps you can begin your talk and you can send our presentation. You can send in your presentation and we can send it out to folks who might be interested in looking at it.
If you can talk me through it very quickly like we did before, and I'm not sure what I'm doing wrong.
Okay. Sure. It's the green share screen button at the bottom of your Zoom screen. That's the first button you pick on your Zoom screen.
On my Zoom screen. So it's a green button, share screen at the bottom, correct?
Yeah.
And for some reason it's not opening. There we go. Let's see.
And for
And
people,
you would select there you go. It's working. Great.
there you go.
And now we just go to slideshow mode. Great.
Thank you. I apologize
so
for
much.
that.
No worries.
Thank you for your patience, everyone. As the COVID long hauler, I think it probably makes sense that I had difficulty cognitively getting signed in. So I would like to talk with you today about living with long COVID, and from the perspective of someone who is a trained mental health professional, as well as a PTSD expert and a COVID long hauler. I'm battling something that is really incomprehensible as a patient who has been living on this sinister journey for 28 months. Medical professionals have been faced with an incredibly complicated clinical picture, one that is highly variable, caused by a novel virus that behaves unlike any known previously. I refer to the myriad symptoms as being on the corona coaster. I think it's important that we acknowledge that many patients have been gaslighted by their physicians because they were unfamiliar with what was going on because of the novelty of this virus. Many of my fellow long haulers have been told that their test results found nothing of significance, so their physicians stopped looking any further. They made a functional diagnosis as the person is suffering with anxiety. Unfortunately, that leaves people who are very sick feeling dismissed and hopeless. And sadly, I must actually acknowledge that despite having the word in my title, I was gaslighted in Florida by doctors who said in the summer of 2020 that they failed to see a unifying diagnosis. After 5 hospitalizations in 6 months and rapidly deteriorating health, I left and went to New York to this Center for Post-COVID Care at Mount Sinai. I was there for 11 months. Fortunately, I had the resources to relocate and seek care. What I hadn't expected, and I really had to come to terms with, was that I would not receive actual treatment. There was no treatment. There was only symptom management. In retrospect, however, I feel very fortunate to have been a part of so many studies. No part of my body was left unexamined. I received considerable encouragement and support from my huge team, and they acknowledged that their patients were being gaslighted, and it was their goal to validate us and create an individualized care plan. The physicians all said, we're learning from you as we go. We're here to help you in all the different disciplines that you need. And in many instances, as you see this list of specialists that I had, I would have 2 or 3 subspecialists within that particular area. Prior to contracting COVID-19 for the first time, I was a very fit and active person until I awakened 2 hours and 20 minutes late for work, and I was very ill. Here are the classic symptoms. Almost 3 years into this pandemic, physicians around the world are starting to acknowledge that traditional tests don't reflect the severity or length of illness that long COVID patients are experiencing. I learned that firsthand when I got to participate in a study using a 7 Tesla MRI PET. 1 year after my initial illness, almost to the day, I still had visible ground glass opacities, bilateral apical and basilar lesions in my lungs, and pleural effusion, none of which were appreciated by my initial physician, who said I simply had asthma and was unwilling to allow me to have a CT of my chest. I still struggle with hypoxia. In the picture you see here, these were actually just taken this past January and February when I was in the hospital. And I think it's really important to understand that I was 18 months post-acute COVID, and I was still suffer with respiratory impact. The studies that I participated are in this very fancy machine you see here. This is where it was realized that I had injury to my brain, my bones, my heart, my lungs, my right kidney, my liver, and my gastrointestinal system. The other 3 photos are from my hospitalization in January of 2022, where I spent 40 nights in the hospital because I developed Guillain-Barré syndrome. Had I not been able to be at Mount Sinai, I would never have evidence of the realities of what I was experiencing. This next slide is a really important slide because I went ahead too fast. It's the policy of Mount Sinai's research team that if you have any abnormal results, they'll communicate that to your consultation team, and the results will become part of your medical record. So I'm very fortunate to have that. Everyone collaborated with me to make decisions about medications to try. Another ongoing issue that I battle is cardiovascular symptoms, which were mentioned just before me. Here's some photos of my journey. I've been hospitalized 16 times over the last 2 years, 4 months. And I was hospitalized. This was my third hospitalization when I was admitted on August 4, 2020, 3 months into my COVID illness. And I had suddenly developed atrial fibrillation. And it took 10 hours before I was converted to a normal sinus rhythm. I was chemically converted. I continue to have paroxysmal atrial fibrillation. And the slides with the 47 and the 194 are recent slides. And the highest my heart rate has been is 224, and my lowest has been 37 when I was just hospitalized this past winter. These slides talk about some of the autonomic nervous system symptoms that continue to persist to this day. I was diagnosed with Guillain-Barré syndrome, and I had all the very typical symptoms of that. And I'm still experiencing a number of symptoms. I am no longer in a wheelchair 100% of the time. I can stand up for a brief time, and I can walk for 6 minutes using a cane. And so I've made some tremendous progress. I can use my hands. I can't hold things very well, but I'm making progress. I still have hypoxia, and my weight fluctuates. My lowest was 96.8 in terms of my weight. Right there, it was 97.7 when I was in the hospital in February. And my body temperature fluctuates as high as 105 down to 96. So I have a tremendous fluctuation in my autonomic nervous system arousal. I struggle with postural orthostatic tachycardia syndrome and orthostatic hypotension, and you can see my blood pressures there. These were, again, very low and very high, all in the same day. It's important to mention that we've yet to confirm the cause of long COVID. It's notable that a Harvard study was discussed in the Wall Street Journal on September 8th, and there's a growing number of researchers who believe in viral reservoirs. The study reveals that a spike protein of the virus was found in the blood of long haulers up to a year after the infection, and that was the length of the study, but not people who had recovered. I am one of those people. The data suggests that viral reservoirs may be provoking the immune system in some patients, causing blood clots and inflammation. More research definitely needs to be done. There are some people who have found fragments of the blood in long haulers like myself. In this slide, you see that I am experiencing a rash. I have had many, many rashes. And in the picture of my foot, that was just in May when I developed another blood clot in my body. This was a popliteal blood clot and behind my left knee. So I've been on Eliquis since beginning of when I was hospitalized, and nevertheless, I am breaking through that medication with blood clots, and my D-dimers were normal. So very interestingly. So the next sort of area of my symptoms is this constant state of allergic reaction, muscle spasms, stabbing pains, GI symptoms that are crazy, and then the blurry vision and very uncomfortable eyes. And this slide is 55 symptoms of long COVID. I have all but 9 of those symptoms and others that aren't on here. And I wanted to draw your attention to a slide of a study that's in the references by Hannah Davis. She's a COVID long hauler, and she identified 203 symptoms that we have been experiencing. And like the speaker before us mentioned, there are a lot of symptoms that aren't being asked about because people didn't know we needed to ask about them. The psychological consequences are really quite significant. And so I wanted to—
1 minute, Robbie, Dr. Robbie, 1 minute, we're almost at the end here.
Thank you. We're almost at the end. I have experienced the 3 in red: anxiety, PTSD, nightmares, where I'm screaming out loud. My entire family hears me screaming, "Help me." And I had a hallucination that involved a goose and a duck visiting me in my bedroom. So I wanted to share where this comes from. I have a beautiful backyard where I have lots of geese that visit and lots of ducks. And in the top corner, you see this beautiful family of ducks born this summer. And I want to know this: why did anyone think this very scary bird, who would certainly cause me nightmares, should be who delivers our babies? So takeaway: long COVID can damage any organ at any time. Long COVID is not brain fog, it's cognitive impairment, and COVID damages our immune system. Resources: Survivor Corps, fantastic organization, very large all over the world. They have great resources for survivors as well as physicians. Mask Together America is another fabulous resource. We have to do something to mitigate long COVID. Masking is, in addition to vaccines, will be helpful. And the last slide is my references. Thank you very much for your time.
Thank you so much, Dr. Robbie. We have Claire Taylor coming up next. Hi, Claire. Let's get you up here on stage. All right, Claire, let me introduce you. So we're so happy you were able to make it here today. Claire is an experienced general practitioner with a special interest in long COVID, postural orthostatic tachycardia syndrome, POTS, mast cell activation syndrome, and ME and CFS. She has a bachelor's in neuroscience from the University of Edinburgh and is especially interested in disorders of the autonomic nervous system. In addition to working for the NHS as a general practitioner, she also operates her own long COVID clinic in Scotland. Very happy you could join us today, Claire.
I'm just looking to screen share.
Sure, yeah, we see your screen, we see your desktop.
Oh, right, I don't see it. Right, I'll get it up.
Thanks. Yes, technology can be not so fun, huh?
Yeah, everybody else can see it but me. Sorry, my husband's helping me. He's here.
Okay. I see it left. We just would like to make your program full screen.
How's that?
It's
Are we
perfect.
Here?
Thank you.
Great. Okay, thank you. Right, better start my clock. It's about 10 minutes. We're whistle stop tour. So my name is Dr. Claire Taylor, and I'm a GP family medicine doctor in Scotland, and have previously worked with ME patients. And about January 21, long COVID patients started coming through. It was a charity, and often they really didn't know where else to go to get help. And I became really frustrated that patients didn't have a doctor that was knowledgeable about long COVID. They're sort of ping-ponging between specialties. So I just set my own up, and I'll tell you a little bit about what I see. So I've pinched this picture just to sort of demonstrate, like the slide before. This is a multi-system illness, and people can have symptoms anywhere in their body. They can have really disabling symptoms. And to sort of draw attention to down here, you know, malaise and fatigue, that's probably what I see most. But the cognitive impairment part, there was a study that showed about 9% of people after a year had cognitive impairment. So you're possibly 1 in 10 people cognitively impaired, and of course all the other systems. So, and credit to these people for the lovely picture. So what I hear most in the clinic, almost always, there can be sometimes a delay, but it's I got COVID and then I never got better. And that's what I hear every day is I got it and I never got better. And the most common symptom I see is fatigue, but post-exertional symptom exacerbation or post-exertional malaise, whichever one you want to call it, this is a really disabling symptom where people, they try to do stuff and then they end up in bed for a week. And it's really, really disabling symptom, sore muscles, shortness of breath, chest pain, cognitive problems, weakness, dizziness, rapid heart rate, flushing, allergy. I mean, just about everything under the sun. And one person could have all of these symptoms when I see them. And you're trying to work out what is going on. And just to note, sometimes people are often unable to work, bedbound, like severely ill. I do video calls to people who are in bed. And I wanted to draw attention to sort of a key point that about normal test results. So normal test results don't mean there's not something wrong with someone. Doctors don't tell your patients there's nothing wrong with them. It means we don't have the right tests yet. We're not doing the right test, or they've not been invented. So, for example, if you think of conditions sort of NMDA receptor encephalitis, it wasn't discovered till 2007. And before that, I don't know what people got told they had, but it wasn't that. And just so we know about this study that looked at patients after being in hospital, they actually measured plasma proteomics. I'm not even going to attempt to even say what all these things are, but safe to say we don't test for them in real life. And they are found to be abnormal in people with long COVID. So we have abnormalities we know about, but we don't test. Microclot testing, there's a lot of talk about that just now. Again, we can only test for in a couple of places in the world. So if you're testing normal guys, it might be actually that we just haven't got the test yet. And I just want to talk about a couple of conditions that I see most commonly in a clinic. And the last talk touched on this, dysautonomia or POTS. And it's a bit like this, people stand up and try to do something and their whole body malfunctions. So it's not a rare thing. There's a spectrum of dysautonomia, POTS, orthostatic hypotension, or the inappropriate sinus tachycardia, which is when your heart just goes fast all the time. That doesn't feel very nice. That's horrible. So people are going about with these symptoms. The last few are, I'm not going to go into detail, but there's other causes. And it's a dysfunction of the autonomic nervous system that controls your heart rate, your breathing, your blood pressure, sweating, body temperature. You can be in sympathetic nervous system controls fight or flight, running away from a lion or something. Parasympathetic is when you're resting and relaxing. A note to say, if somebody's got sinus tachycardia and you don't find another cause, well, think about dysautonomia, think about POTS. People get told, oh, well, you've got a sinus rhythm, fine. But think about standing somebody up and testing them. And this overlaps with the picture of all the symptoms, the first picture. So look at all the symptoms people can get, multi-symptom again. And in my clinic, I'm trying to work out which ones have got POTS, and it tends to be the ones that don't like being upright. It doesn't feel very nice, and get blood pooling in their feet and things. 80% are female who have POTS, and obviously a lot of my clinic is female. Study in March 21 suggests 50% of people have POTS. It's maybe not quite as high as that, maybe about 40. But if you work it out with how many people in the UK have long COVID, possibly 1.5% of the population have got this, and we hardly talk about it or know what to do with it. And there was a study in 2019 that shows that, again, things are off, cytokines are up, chemokines are up, we don't check them in normal practice, autoantibodies. It's a real condition, and there's good evidence for that. Patients still get told it's not a real condition. I diagnose them with it, they take it back to the doctor, and they say, well, so what? What's that? So we need to take it more seriously as a real condition. Not going to too much into the diagnosis, but if your heart rate goes up by 30 when you stand up and your blood pressure doesn't drop, that's POTS. You can do it with diagnosed with a tilt test or a NASA lean test, which is standing up for 10 minutes. I prefer that. People can do it at home and they don't crash because they've spent a day going off for a tilt test. So there's benefits to tilt tests, but actually you can get a lot of data from a stand test. And one of my patients very kindly did this. So this is somebody's heart rate going along quite happily at 80 beats a minute. They stood up, they were up at 120, and then they lay back down, and it's back down. And the blood pressure is pretty stable. So that is POTS, and patients can do this at home and show it to their doctors. Amazing. There's loads of advice for anyone that's got POTS. POTS UK website, brilliant. Fluid can reduce your heart rate, increasing salt, compression stockings, and there's medications available. Another patient, not my patient, but Harriet Carroll donated this to me, thank you very much, to show what happens when you take salt with POTS. So that's her lying down, that's her standing up, and this is pre-salt, this is with a little bit of salt, and this is lots of salt. Look how much her pulse has come down. Amazing. That's not even with medication. So thanks for donating that to my talk. And then the other condition I wanted to talk about was mast cell activation syndrome. This is where people react, either they have too much histamine or the histamine is inappropriately released. They come from mast cells, little cells in the blood, first line of defense. And long COVID seems to do something to that part of the immune system where they just start piling out histamine. And again, multi-system symptoms. People are often told they're anxious, and triggers vary between individuals. Anything can set it off, and sometimes nothing. So my patients aren't doing anything and they're getting symptoms. And this is the symptoms, again, like the other ones, huge amount of symptoms. If this is available afterwards, you can have a read down them all, but flushing, fatigue, headaches, alcohol intolerance, etc. It's degranulation of mast cells. They release loads of things that are not very nice, histamine, heparin, cytokines. There are tests you can do, but they can still be normal if you've got the condition, actually. So it can be helpful, but sometimes not. No agreed diagnostic criteria, tests from reliable. So if you've basically got a syndrome that looks like it, and then you clinically improve with the treatment, we can say you've got MCAS. Management, low histamine diet helps some people. Then you want to block all these histamine receptors, stabilize the mast cells, avoid the triggers, and hopefully somebody's in a better position than they were before it. Another wee word, key point, guidelines are not tramlines. The nice long COVID guideline that we use in the UK, this is the bloods that are on it. I've never seen a raised BMP. I've done loads, there will be, but it's, to me, it's not as important as we don't do a D-dimer, it's not on it. And, we need to find clots, basically. And in my clinic, I've now got people who 2 years into the pandemic have got negative blood tests for clots, normal scans for the traditional scans we do, normal CTPA. You find the clots on a VQ scanner, which we hardly ever do. And there was a paper here was talked about how they found extra clots on dual energy CT. I've been trying to find out if there's one in Scotland. I'm not sure there is. And so we need to find these clots. So, we're treating things like MCAS, we're treating things like POTS, which is great. As a doctor, it's really frustrating for me because I want to put everybody through a scanner. And as patients, it's frustrating because they have waited now 2.5 years for treatment. And I think we need to move quicker. And I'm really pleased to hear we'll be hearing from people later on talking about this sort of thing. Patients don't have years to wait for all of these trials that are all about to start. So if you're going to take anything away from the talk, find the clots. Guidelines are not tramlines, and normal tests don't mean there's nothing wrong with you. The end. Exactly 10 minutes.
Thank you so much.
No problem. Whistle top tour.
Thank you so much, Claire. All right. So next, we're going to move to Dr. Benita Kane. Dr. Benita, I'm going to bring you up here. Here you go. Hi. Dr. Benita is a consultant respiratory physician and honorary senior lecturer at the University of Manchester in England. She is a member of Independent Sage and a champion for the charity Long COVID Kids. We're really pleased to have you today.
What can you see? Can you see my presenter view or the slideshow view?
I
Did you see anything?
I do see your view. I see
See the Taj Mahal?
it looks like a working view, not the presentation view.
Okay, let me just stop sharing my screen just for a second. Okay, let me just try something else.
Thank you. Take your time.
Is that working?
If you just play, oh, I see, it's overlapped. Interesting. We have your slideshow behind your PowerPoint program.
Okay, right. We're getting closer then.
Closer.
Just 1 second. Let me just
Sure.
try something else. How about this?
If you click play from start, what about use slideshow?
I don't understand. So when I'm sharing my screen, it's coming up as, okay, so you can see that.
Yeah. This isn't bad if you want to play it like
Can
that.
you see that?
View from this
Oh,
view.
use slideshow.
Switch view.
We got it?
There we go.
There you go.
Got it. Amazing. Right. Okay. I'll try and shave a minute off to make up for that. Sorry about that.
Thank you so much.
So I just want to thank Claire for and also Robbie for just beautifully kind of saying a lot of what I had planned to. So I'm going to share a personal journey. It's not about me, actually. It's about my daughter, Jasmine. And she overall has been ill for about 18 months with long COVID. Now, she was 10 years old when she first got ill. And before she got ill, she was just a normal, healthy, happy 10-year-old. She loved doing gymnastics. She loved swimming and just being active. And she had no health problems. The first 12 months of the illness was really difficult. She was plagued with lots of different symptoms. She had a lot of symptoms we've already discussed: severe fatigue. She needed a wheelchair for long distance, and it affected every part of her life. And she could barely go to school, and she really lost everything. I'm pleased to say that over the last 6 months, there has been a steady but slow but steady recovery. And we've got her to the point where she's now back at school full time. And I'm going to just talk a little bit about how we got here. So just to go through the timeline, as I mentioned, the initial illness was in January of 2021. And a bit like Claire said, she got ill with a pretty mild illness, but just never got better. So she was left with fatigue. And about 3 weeks after the initial illness, she developed very severe abdominal pain, was rushed into hospital. I thought she had appendicitis, had all the tests. And like we've discussed, the tests all came back negative. At this time, it was lockdown. She wasn't going to school and was dipping in and out of online lessons. So she was resting a lot. And the real turning point was when school started again in the March, and she went back full time, even though she wasn't quite right. We felt that was the best thing. And in hindsight, what then happened was this now what I understand is a boom and bust cycle. She would go in, it would just be too much for her. Then she would crash. And this would happen every 10 days, 2 weeks, she would have a crash until about the April when she got really poorly. And this is when we got her assessed by pediatrics. And I'm a doctor, so I'm able to access healthcare quite quickly, because one of my colleagues in the hospital saw her, which we were really lucky. But she had this whole raft of tests and they all came back negative. And so they said, well, she's got ME/CFS, go off to the clinic. We then decided to focus on her health and removed her from school. And that was a really difficult decision. We then waited several more months to get into the MECFS clinic while she was just ill and at home. School attendance at this point was about 20% because she could go in maybe an hour 3 times a week, if that. And we went to the clinic, and now we're getting towards sort of September, October, and we were offered physio. And we followed the advice, but unfortunately, the advice led to her crashing further. And at this point, we disengaged from the clinical service, from the NHS. Everyone was very nice, but we were despairing that our child was very sick and we weren't getting any help. And so at this point, I say we go a little bit off piste. I had started connecting with international researchers, people like Risho, who's going to be on the call, on the webinar later, but other people in Germany, South Africa, elsewhere. And we started looking at alternative treatments based on the science and based on what we know. Now, because I've only got 10 minutes, I can only focus on one aspect. So I'm going to focus on the thing that really made the biggest difference for us. And that was in February this year, we flew over to Germany. And this here is Dr. Beate Jaeger, who is now quite famous in long COVID circles. So we went to the Mulheim Clinic. This is Dr. Asad Khan, my very good friend and colleague who helped facilitate that. And you can see Jasmine's in a wheelchair. She's looking pale and withdrawn. And we had her blood test done, her research blood test that you can't get on the NHS, or as has been mentioned, is only available in a few places in the world. And she had microclots. And these are her platelets, which were extremely clumped together and very, very abnormal. Now, why does it matter? What is this clotting, abnormal clotting doing in children? We don't know is the answer, because hardly anybody is looking. You know, there is a real dearth of research in children, but there is this one study which came out of Germany. It's a preprint, it's not yet published, but they looked at 54 children with COVID, half of whom had recovered, half of whom had long COVID, and 9 healthy controls. And what they found with this very specialized MRI testing was widespread defects when compared to the healthy children. And what was really worrying is even in the children who'd recovered, they also had these defects in the lungs, which we think were caused by clots. So there's something here about actually just having COVID, even if you recover, can leave some damage, which is quite worrying when it's our children we're talking about. And there is overwhelming evidence from the adult world now that a very key underlying mechanism in long COVID is the inflammation of the blood vessels. It's not the whole answer, but it's a big piece of the puzzle. It's a thrombotic vascular disease, so blood vessels and clotting. And the virus, it replicates in cells, and it's postulated that it's carried outside of those cells by these little extra cellular vesicles, and it's transported around the body, and then through various different interactions, it can cause injury to the blood vessel wall, which can cause the clotting. And platelets are also very important in this. They become hyperactivated. And so you then end up in this vicious circle where you've got the clotting, the platelets, and that causes more injury. So you end up with this thick, sticky blood, which can't get through the capillaries, can't give oxygen to the major organs, particularly the muscles. That can cause this chronic sort of low oxygen levels and be one of the mechanisms for the fatigue. But as Claire and Robbie have talked about, there's also other mechanisms that can result in the fatigue as well. So I don't have time to go through this in detail, but these are some of the treatments that we have sequentially tried over 6 to 8 months. We've been to Germany 4 times since February at quite a lot of expense to tweak the combination of things. But we have used sort of some of the simple stuff like the supplements and the vitamins that's for inflammation. Pacing and energy management has been key. Melatonin for sleep. Claire mentioned the vagal nerve and the autonomic nervous system. So there's been some stuff we've done to try and counteract that sympathetic overdrive, that fight or flight. But actually, the thing that has made the biggest difference has been blood thinning treatment and antiplatelet therapy, which again is really not used routinely in children and needs supervising and monitoring. That's very important. She's also had some of the probiotics for the gut, and more recently been started on a drug that will stabilize the endothelium and, dampen down some of that blood vessel inflammation. And I must stress, this has been me as a consultant with advice from world experts at every step. I've got an Italian pediatrician, South Africa, Germany, and others where we have sort of all discussed how we manage this. And what I really want to do now is bring this research and bring this treatment to other people. And what has worked for Jasmine may or may not work for another child. And that's what we really need to understand. But here she is on our summer holiday, first family holiday in 3 years. She was able to swim, and now she's back at school. She started high school in September, and she has so far managed full days. Apart from doing PE, you wouldn't know that she was ill. And she remains on a lot of this therapy. And the biggest challenge now is how we start weaning her off it and how long. So my take home message is,
we're out of time, Dr. Benita.
We're out of time.
Yes.
That's fine. That's my final slide. Key points. There are treatments. You just need to be able to access them. And we need research.
All right. Well, thank you so much, Dr. Benita, for sharing your personal story of your family and all of the important information. We're now going to transition over to our Q&A. So Jason has been dropping the form. If you have a question, please drop your question into the form, and Geraldine will be asking questions. And now I'm going to bring up Dr. Benita to the stage again with Claire and Dr. Claire Taylor and Dr. Robbie Tamargo and Geraldine Hamilton.
Thank you, everybody, for some incredibly wonderful talks. I have one question for Dr. Nyberg from the audience. You mentioned, do we have, there we go, I can see her now. You mentioned that the virus enters several different types of immune cells. What are the consequences of that? And does that mean that patients who've been infected, particularly multiple infections, are therefore more susceptible for other infections or effects of long COVID, perhaps?
So that's a very good question. And I don't think anyone at this point can give a certain answer to that question, but there is evidence that the immune system goes through changes for quite some time after COVID-19 infections. We can see that on T cells, on the number of T cells, the different T cell populations, and other measures. And the one study I mentioned about monocytes, you could see that at the time of the study period of the study, they could see that 6% of the monocytes were actually dying from this infection. So, and we don't know yet what that means in the short run or in the long run. And but there are some signs that it might lead to people being more susceptible to other infections. But for the long run, we really don't know anything about it yet. But there might be effects.
Thank you. I have a question that perhaps each one of the other speakers, Dr. Kane, Dr. Tamara, and Dr. Tyler, could answer each one. It's for patients suffering from long COVID who do not possibly have access to those tests that are not regular, like the fancy scans that you mentioned, the biomarkers or blood work that most people don't have access to. What is your top advice to them as to what they can do, what they can ask, how they can better educate the physicians to help them?
Do you want me to kick off with that? So I think one of the key abnormalities that we are seeing in a lot of long COVID patients, as Dr. Taylor said, nearly 50% will have this autonomic dysfunction. And a really good measure of that is something we call heart rate variability, which can be measured quite easily with with a number of different gadgets that are already out there. And there's some really good videos on physios for ME. I mean, the ME community have known about this for a long time, and we're learning so much from people with ME CFS. And so I think in terms of that pacing and not getting into that boom or bust, using heart rate variability and to manage exercise levels and to manage fatigue with pacing is a really good idea. And also anything that will help stimulate that parasympathetic nervous system, like meditation, breath work. That's all very, very good for people with long COVID, but I'll let others speak.
Dr. Tamargo?
I agree. One of the programs that is available at Mount Sinai is a breathwork program called Stasis. It's part of the rehabilitation program there. And I was an early person in the rehab program because I was in the first wave essentially. And I was taken to the hospital and admitted 3 times from physical therapy. And and I wasn't really doing anything profoundly taxing, but the doctors here will understand. One of them, I had to put a ball up a wall, having my hands over my head, and I just went down. And another was getting up from lying down, and I became very disoriented and I looked apparently very odd, and they ended up calling a code on me and taking me to the hospital. So I think letting people know about how important the pacing is. Most people don't understand that. They think they should be, and physicians have said that, and I've been told by a cardiologist that I should just get back to running like I used to. And I just laughed. I'm like, golly, I can't go up the stair steps. I can only do 2 steps at physical therapy. I can't imagine. I can only stand up for 6 minutes. You know, what in the world and are they thinking? So they're just not COVID aware. So I share with other long haulers, ask for COVID aware physicians. And my physician, my primary care doctor, who was my second because I had to fire my first, has stayed with me the entire time. Even when I was in New York, we had a weekly video session, and he has kept contact with me this entire time. And so when I went to see him the 1st of January, that Monday after the New Year, he said, oh my gosh, you need to go to the hospital because he had been seeing me and knew that I was in trouble. So I think having a COVID aware physician, if you don't have one, try to find one. There are resources on Survivor Corps for that, on Mass Together America, and all of these docs that are here, Dr. Taylor, Dr. Kane, Dr. Nyborg, they're on Twitter and Facebook, and they're posting things. So they will help you find a COVID-aware physician near you. And whether it's in the United States, the UK, or wherever you are in the world.
I'd like to give Dr. Taylor, if you wanted to comment on that question. Any guidance or tips for patients who don't have access to all of the more research focus, the access tests, complex tests?
Okay. Well, I have to say most of my patients haven't had any complex tests actually, and I've seen what some of the stuff that's done in the States compared to here, and it's a huge difference. And I think you can do your own stand test. So if your doctor doesn't know about POTS, for example, show them what happens to you, and don't let them tell you that it's not POTS. Show them a graph. If you can, do something to show them this is what's wrong with me. And I know it's difficult to advocate for yourself when you're not well, but maybe take somebody with you if you've got somebody that can come with you. And I think, like we said, seeking out people that do know if you can lobby sort of MPs. In America, it might be congressmen, is it? And Facebook groups and things can be really good for patients who don't know what they need. For example, if do you need a complex test, or what do you need? So I would say to make use of all of that sort of thing as well.
Thank you so much. And we have many more questions, but we have to move on to the next session. We have captured the questions so we can always share them later. Thank you, everybody. So handing it over to Katie, who will introduce our next speaker.
Thank you so much, Geraldine, and thank you to all the doctors for those very insightful answers. So we're moving on to session 2. We're very excited to have Professor Andrew Ewing visiting us here. Andrew has obtained his bachelor's degree from St. Louis University and his PhD from Indiana University. After a postdoc with Royce Murray at University of North Carolina, he joined the faculty of Pennsylvania State University. In 2007, he obtained a Marie Curie chair to move to the University of Gothenburg in Sweden. He was elected to the Royal Swedish Academy of Science in 2012. Currently, Professor Ewing works are mainly based on nanochemistry, electrochemistry, optical imaging, and imaging mass spectrometry to elucidate basic chemical mechanisms, as well as drug responses of neural communication in single cells, cell networks, and model nervous systems. All right, I'm going to pull up Andrew onto the stage.
Okay.
Go ahead.
Okay, thank you for the invitation, and happy to be here. I'd say great talks, but they're really almost depressing. I mean, it's this whole area. There are long-term effects of COVID on the brain, and I think we all know that. We've heard some of this already. A little bit of a summary here is SARS-2 might attack certain brain cells directly, and this is a big issue people fight about. Reduce blood flow to the brain tissue or trigger production of immune molecules that can harm brain cells. And it's the latter one that I think is going to end up being the worst, but we'll see. Memory loss, strokes, and other effects on the brain occur. Some neurological symptoms and damage are the result of the body's own immune system overreacting. A beautiful paper just out this summer came out in a preprint in January by Iwasaki and co-workers showed that very nicely in a mouse model relating it to humans. COVID survivors have 10 to 15 times higher risk of considering suicide at year 1 at 1 year after COVID than 11 million control patients, and that's in this reference down here at the bottom. Just some staggering things, and I mean, I could go on, but I've only got 10 minutes or 9 minutes. Oops. Okay. This is a really famous paper, I think. It actually came out a preprint about a year before it came out this year. I was reporting on this earlier, and then it changed a bit. It was a lot of fighting because people didn't want to believe it, especially people who had COVID. Scientists that had COVID didn't want to believe that their brains had shrunk. But basically, this paper used magnetic resonance imaging to show that the gray matter, the matter in the brain that is the nerve cells, okay, mainly nerve cells, and I'll talk about white matter in a minute. That it shrinks, okay, in certain specific parts of it, and these are just these pretty images, but that they come out with. But these are spots in the brain where they're actually seeing shrinkage, and they localized with their imaging technique on these brains, and these are all human brains. So they looked at these, and they had patients before and after COVID, so that they had imaged, and they brought them back in this a large biobank project that they had already had set up, not realizing that COVID was going to come along. Here they look at the parahippocampal gyrus, which is involved in memory formation and processing, and they look at the orbitofrontal cortex, which is the part which is involved in decision making, most often thought, and they show that there's a decrease, and I'm not going to go through the axes, but this is from 0 from the control down, and there's a decrease of about 3% in the thickness of these. I mean, 3% doesn't sound like much, but it's a lot. Okay, that's a big difference. If your brain is shrinking during COVID, I mean, maybe this is why you get serious headaches. but it also leads to problems. And I mean, I don't know how many of you anecdotally know people who say this, but I mean, about half or more of the people I talk to who have had COVID tell me that the biggest problem they still have is making decisions or the decision, the process of using the knowledge that they have. There's another study that came out in 2021 that has been publicized quite a bit, where they used the Great Britain intelligence test. I don't know if that's, no offense to, never mind, I won't make a joke. But they looked at 81,000 plus patients and with different symptoms of COVID, and they had, these people had taken the intelligence test before and after. And this is the original Wuhan version of the COVID, and they found that there was a decrease in their IQ in this intelligence test, and it's a bit of a complicated series of things that they work on. That it gets more serious with more severe COVID, but it's shown in all, even patients that have very mild COVID. And the bottom line is this axis shows a drop of about 7 points in IQ. Okay, and they argued that, I mean, this amount is about 10 years of aging. This is what you usually lose in about 10 years of aging. What can lead to impaired neurogenesis in the hippocampus, which is the memory and learning area of the brain? Well, the cytokine CCL11 was shown in this Iwasaki, Monge, and co-workers paper in Cell that I mentioned before. This was elevated at 7 weeks, both 7 days and 7 weeks, but I show here after mild respiratory infection in mice. And it was also elevated with humans with brain fog. Very, very similar, right? Neuroblasts, these are cells that are formed during memory formation. These are shown to decrease, okay, with a mild infection in these mice, the mouse model. So it's really, we're getting more and more data that shows what the mechanism is, and it's not good. It's destroying cells. If you look at a nerve cells this is sort of a garden variety view, okay? They're really more complicated than this, but they have a cell body, and then they have a place where they release neurotransmitters. And they have to send a signal down this part called the axon. And these axons in mammalian cells in our brains, a lot of the axons need to have faster transmission in order to work well. And so they create something called a myelin sheath. These are different kinds of cells. And this is white in a picture, okay? So they call it white matter. And this investigators here, Peterson et al., looked with MRI imaging, and this just came out in a preprint, and they looked at this, and these are the images. They look kind of like scary pictures from some rock band, but they showed that they looked at water analysis, okay, and they water analysis showed that the water, when it goes up, that means there's less white matter, so you're losing these white myelin type cells, or cells that make myelin. Okay, now I want to point out that myelin is destroyed by the immune system in multiple sclerosis. Okay, this is really scary. In the paper, and Eric Topol put out a tweet on this, he said, oh, this is very promising because they didn't notice cognitive deficits when they did this study. But the reality of it is, okay, that the future of these patients where they've lost this could be very grim. We don't know, but it's really a scary idea because we're talking about affecting a part of the system that leads to diseases like multiple sclerosis. And they observed this in 38% at a mean of 9.7 months after the COVID. Okay, is it recoverable? No one knows. Okay. Okay. This is a controversial set of data that was published from it's an American military study where they had patients that died for other reasons. But these patients, they ranged from 58 years old to, I think, 37 years old. So they call them young patients, okay? They're not the typical over 75 or whatever. And these patients, almost all of them had some kind of clinical problem otherwise, but all of the patients, and they looked at more, I forget the total number, but every single patient they looked at had these plaques inside which are characteristic of Alzheimer's disease. Every single one of them, and these are pretty young patients. Okay, now the reason this study is controversial is because the patients that you see the same types of plaques formed if your people are on respirators and really, really bad condition for a long period of time. But not all of these people were actually on that, although they did have other comorbidities, although I hate that word, comorbidity. But it's still a scary view to think about. So we don't know yet, but if this is happening, if we're forming plaques even in young COVID patients, then our future is on the line here. We're time bombs. This summer at the 8th European Academy of Neurology Congress, a study was reported. I haven't seen an actual. I've seen this written up in Medical Express, but I haven't seen a paper on this yet. But a study of over 900,000 patients, and and 43,000 positive. Positive cases had 3.5 times increased risk of being diagnosed with Alzheimer's disease, 2.6 times higher with Parkinson's, 2.7 times higher with ischemic stroke, and 4.8 times increase with intracerebral hemorrhage, bleeding in the brain. Yuck. I know. I got to finish up. Takeaways. Thank you. Thank you for that, for showing me, Katie. Even mild COVID can lower cognition. Cognition reduces gray and white matter in the brain. COVID increases chance of stroke and other neurological manifestations, even in younger patients. Simply put, COVID can damage the brain, okay? I'm scratching the surface here, but there's so much more out there. We need to address organ damage that is insidious, so not showing up in the symptoms of long COVID. Almost guarantee that we're going to have a lot of long-term damage not showing up now, especially in the brain. Fog is bad, protein tangles is a disaster waiting to happen. Thank you for your attention, and here's some good Twitter threads, one by me from February and one by Dr. Wes Elia, who's fantastic more recently. I'm not hearing you, Katie.
All right, thank you so much, Andrew. I always enjoy your presentations, as frightening as they might be.
Sorry, I'm a fear monger, but I think we evolved with fear, okay, and we evolved with fear for a very good reason, okay.
So change in the program, unless Ray Duncan has a different name on her screen, which is possible. If so, please come forward. But I think we're going to move to Amitabha. If
okay.
That's all right.
I was looking for that talk.
Hi, can you hear me?
Yes, thank you. All right, let me introduce you, Amitabha. This is Professor Amitabha Banerjee.
Banerjee.
Thank you for the correction. I would love to say everyone's name correctly.
No problem.
Absolutely. All right. Professor in clinical data science at the University College in London and honorary consultant cardiologist at University College London Hospitals and Barts Health NHS Trusts. As a researcher, educator, and clinician, his interests span data science, cardiovascular disease, global health, training, and evidence-based healthcare. He has been active both clinically and academically through the pandemic and is leading a large national long COVID study, Stimulate ICP, which includes a large platform drug trial. So pleased to have you today. Turn it over to you.
Okay, it's evening time here, but hello everybody, whatever your time zone. Amitabha is my first name, Ami for short. My email address is there, and Twitter as well. So my topic is the challenges and opportunities in clinical research in long COVID. These are my conflicts of interest. I have research grants from AstraZeneca, the National Institute for Health Research, BMA, which is the British Medical Association, UK Research and Innovation, European Union, and the important one there is that I'm the chief investigator of the NHR-funded Stimulate ICP study, which I'll touch on later, I'm also a trustee of Long COVID SOS. You may have seen this week the WHO statement that there's just in the European region 17 million people with long COVID in the last 2 years, and the WHO urging people to take this seriously. In the UK, you've already heard that the WHO definition of 12 weeks or more is met by at least 1.8 million people. The Office for National Statistics estimates, and we're coming close to 500,000 people with over 2 years of symptoms. And I think this fits the description of a syndemic. We've talked about pandemics, but there's syndemics which go beyond thinking of just infectious diseases, but more chronically. And just to orient you, this is as much as many other chronic conditions, if not more. So look at the numbers for dementia, heart failure, coronary heart disease, and COPD in the UK. Now, I think of things as I'm a data scientist, and I think of things in terms of where the data is missing. And this concept of the learning health system is useful, where you have science or research, you have how doctors, nurses, physiotherapists, other health professionals are providing care, and you have evidence and guidelines, and we've got gaps in all three. And that happens whenever there's a new disease. But what's different here is the scale and the severity. So we're lacking guidelines. We've got lots of gaps in the science, and so it's unclear how to treat properly. And I've in a publication here with my colleague Mohammed, we applied this to long COVID, and you can think of long COVID in the context of direct and indirect effects, as well as the long COVID effects. But you've got mechanisms, risk factors, trajectory of long COVID where we're finding out more, but we still haven't got it fully sorted out. The evidence is needed in terms of guidelines for prevention, management, investigation. And where we want to get to ultimately is improving patient care and what we call integrated care. So treating people across the pathway, doing better at risk prediction. The one thing that's certain is in all of our countries that you don't get long COVID if you don't get infected. So there is a role for prevention. And this part of the continuum shows that we want to pick it up early, we want to assess early, we want to monitor early, we want to provide care early. I'm going to very quickly rush through this, but we've been working on this for a couple of years now. This was data that we published in preprint in 2000 and late 2020, early 2021, showing that multi-organ MRI in over 200 patients with non-hospitalized long COVID had a plethora of symptoms, but importantly, they had organ impairment on MRI. I've just circled the myocarditis, so that's heart inflammation. Pink is ongoing severe symptoms. Black is where people have recovered from COVID, and grey was people who've not had COVID. And across most organs, the people who had more severe symptoms had worse MRI findings. We went on this just to show you the delays in publication. We I think put this in preprint in April of this year, where we followed up these patients, of which the original cohort was over 500, and then we followed up people who had MRI abnormalities, of which there were 330, I believe. And we, on the top of the slide here, you can see that in light blue is the baseline, blue is the 12-month follow-up. And the good news is that for all of them, the symptoms are getting better, but they haven't totally resolved. And here we've got the MRI findings where they were persisting to a large extent in at least a third to 2/3 of people. that's non-hospitalized. And hospitalized, we showed very early on. And I'm showing you this not to show off our work, but to show that the time it takes to do the research, publish the findings, and then to do something about it. Because we showed here that in hospitalized people at 4 months, this is pre-vaccination, at 4 months, 12% of people had died despite being discharged from hospital. 30% had been readmitted to hospital, and good numbers were getting new chronic diseases, diabetes, major adverse cardiovascular events, chronic kidney disease, chronic liver disease. So this has changed completely since vaccination has been introduced, but it's still worth paying attention to. The hospitalized COVID does lead to chronic impairment. That's the science side. The cover scan, the multi-organ MRI, is a way of assessing in a one-stop shop. I think Claire in the last session said that rightly that individuals with long COVID have been bounced around the system for different scans or so. This was the first approval of a diagnostic for help in mapping the effects of COVID in one place. And the UCLH clinic, where my colleague Dr. Melissa Heitman leads the service, so that's at University College London. She set that up in April, May of 2020, so prescient really. And since then, they take about a third of their patients are post-hospitalized and 2/3 are non-hospitalized. But even in our early data from that clinic, which was about 1,200 patients, what we're seeing is we've split out this is the overall, but we've split out the non-hospitalized, the hospitalized, and people who came via the emergency department, the ED. And you can see that if you're just taking a look at who's employed and what's and how that's changing over time, you can see the proportion of people who are part-time or not working at all, not employed, is high, even in the non-hospitalized. And so the impact on economy is huge. And this isn't a research cohort that's curated. This is a real clinical cohort. And when you look at particular symptoms, they have more of a connection with poor health. So in this case, people are rating their overall health, and obviously if you have brain fog, that's a substantial impact on your overall health. So it does sound like not good news that we've not got fully evaluated investigations, drugs and rehabilitation, but we have got lots of studies going on. There's preliminary data and people have tried lots of different drugs. These three here I mentioned because we're looking at them in our trial, but we definitely need to be integrated in our care and looking across disciplines. There's huge opportunities for patients. We've been led by patients. Patients showed us what this disease is. Patients are curating and publishing research in this space, including in our own research team. There's thanks, Katie. So and the clinicians, researchers have opportunities to collaborate more, but we need to think about also across long COVID to learn from other chronic diseases and learn beyond the pandemic. The challenges are many. There's the challenge of not enough time. We need to be quicker, but the problem is that science at scale takes time, and particularly clinical trials take time. And in the world where we are making sure that long COVID stays a priority and that there are enough resources, this is our study, Stimulate ICP, Symptoms, Trajectory, Inequalities in Management, Understanding Long COVID to Address and Transform Existing Integrated Care Pathways. I'm going to run out of time, but there's 3 parts. Firstly, to look at current care evaluation. In the UK, in England, we have 90 long COVID clinics, which are doing different types of assessment, and we're assessing what has been done and where the gaps are. Second part is a complex intervention trial where we're looking at the left here, cover scan, the MRI scan that's looking at different organs versus not usual care. We've got an embedded nested drug trial with rivaroxaban, a blood thinner, colchicine, an anti-inflammatory, and antihistamines, loratadine and famotidine, which are in a platform design. And then we're also looking at living with COVID recovery, which is digital rehabilitation against usual care. In the final part, my colleague Nizreen Alwan and other team members are looking at inequalities in care and comparing long COVID with other chronic conditions. So take-home messages are, there's not one research method here that's going to give you the answer, whether it's trials or basic science, and because there's not just one mechanism. So we need lots of methods and lots of disciplines. We need greater coordination across countries and within countries and across studies and across people who have the disease, clinicians and researchers. And I think long COVID is learning from other post-viral conditions and other chronic conditions, but I think it's already teaching us a lot about what we should be doing beyond the pandemic and even now in other long-term conditions. Thank you. You're on mute, Katie.
Thank you so much, Amitava Banerjee. It's great to have you here with us today. So we do have Ray Duncan here. I'm so glad you're able to join us, Dr. Ray. So I'm going to go ahead and spotlight you now. And I'm going to give your introduction. So Dr. Ray Duncan is a cardiologist focusing on the impacts of long COVID. Dr. Duncan set up one of the first long COVID cardiovascular complications clinics and ran it for almost a year. She has designed and written 4 separate long COVID treatment trials on both sides of the Atlantic, which are in various stages of setup. Dr. Duncan is a medical champion for the Long COVID Kids charity and strongly believes we should be doing more to protect both children and adults from repeated exposure to SARS-CoV-2. She has also recently joined our expert advisory team on long COVID here at the World Health Network. Thank you so much, Dr. Ray.
Thank you so much for having me. I was actually in the waiting room. I just wasn't able to talk, so I'd been muted. So we've heard some fantastic talks already. What I want to do now is just talk about the longer term cardiovascular effects following SARS-CoV-2 infection. So as you will have already heard from some of the other speakers, COVID is predominantly, and certainly in the case of long COVID, is predominantly a vascular disease. It is a disease causing inflammation and clotting abnormalities in the blood and the blood vessels, which then has a knock-on effect on all of the other organs. Therefore, it's perhaps not surprising that there can be lots of cardiovascular and thrombotic meaning clots, complications. And I'm just going to take you briefly through some of the landmark trials looking at these very quickly. So the first one is a very large Nature paper that came out of the States looking at the records of 12 million people. Over 153,000 of them had COVID. They were followed up for a 12-month period. And this demonstrated that there was a significant increased risk in myocardial infarction, which is the medical term for heart attack, heart failure, heart rhythm abnormalities, stroke, and thrombotic death, and other cardiovascular complications. This occurred not just in hospitalized, but also in the non-hospitalized, allegedly mild, and I don't like the term mild because I don't think COVID is mild in anybody, mild cases. So the compounding variables with this study, it was followed up for 12 months, so it pertains to patients that were predominantly infected with Alpha and Delta. We don't know if the adverse events are as bad with Omicron. We don't know that yet, but we certainly should be looking at it. And this was done in a VA cohort, so some of them were slightly older, but there was a subgroup analysis which showed that actually these risks were present even in younger patients, even in those with no underlying health conditions. The NACME registry data, some of you may be aware of, in the UK and in the US, we have a database of all the ST elevation myocardial infarctions, or STEMIs, which are the very large, dangerous heart attacks. Now, what usually causes them is you get cholesterol plaque disease in the blood flow to your heart. one of these plaques becomes unstable and ruptures and a clot forms over it, and it blocks the artery, and then you have a heart attack. However, in patients who've had COVID, when we've taken them urgently to the cath labs and done their angiograms, in a third of women and up to 18% of men, there is no obstructive coronary artery disease. This is called MNOCAS. And this is very, very unusual. It's normally around 5%, 30% is unheard of, and it predominantly would fit with the underlying pathophysiology of a thrombotic endothelitis. Now, this is interesting as well because it's slightly more difficult to treat. You can't treat it in the standard way because there's no target lesion, and inpatient mortality in this study was shown to be higher. Now, that could be for a lot of reasons, not just because of the MNOCAS, but it certainly is something that needs to be looked at. A further paper looking at the cardiovascular complications, also printed in Nature. This was around 3 million patients over almost 300 hospitals over 3 continents. And ultimately what it has showed is that there are increased cardiovascular and thrombotic events, predominantly in the mid and later stages of the disease. But actually there was almost more in those that weren't hospitalized than in the hospitalized group, which I found quite interesting. The Swedish have had a look too. So they have had almost 9,000 patients with COVID, and they've studied them, and they actually studied them predominantly for around 4 weeks around the time of index infection, and showed a significant increase in both heart attack and stroke. Now, this is a US study. It's a preprint, so it's not yet been peer reviewed. So we just need to bear that in mind. But it's looking at over 1,000 patients. And what they're trying to do is get away from this concept that just because the acute illness it may be mild in some people, that actually the whole thing is mild. I don't think there is such a thing as mild COVID, if I'm being honest, because we have no idea of the long-term effects. And what this study has shown is they have taken all of these patients involved in it were non-hospitalized, mild COVID cases. Some were symptomatic, others were completely asymptomatic, and their COVID was picked up on routine LFT and PCR screening. And what they have showed is that the major adverse cardiac events, that's MACE, were still elevated even if you were asymptomatic from the index infection. And predominantly the events were quite late as well. On average, 10 months, they followed people up for 500 days, 10 months after index infection. And there was also an increased risk of death, both in the symptomatic and asymptomatic COVID groups compared to non-COVID controls. So moving away from the vascular complications, cardiovascular complications of COVID, to the inflammatory cardiac complications of COVID. This is a paper that's just been published by Ike Nagal's group. He is an imaging cardiologist. One of the things that we can see is myocarditis, which is inflammation of the heart muscle. But again, this was looking at a group of patients who actually had mild COVID, allegedly mild COVID, and non-hospitalized. Now, they had lingering symptoms of atypical chest pain, palpitations, and shortness of breath, but nothing that would trigger a routine review for myocarditis or any other high-risk red flags. But when they did cardiovascular advanced image, and what I should say is the routine tests were normal, but when they did advanced parametric cardiovascular imaging on these patients, there was an increased T2 signal in the parametric mapping. Now, what that means is there was increased water content or increased swelling subclinically in the hearts. And this suggests that even in individuals who allegedly have not had an acute severe index infection, they may still be having subacute myocardial inflammation. And this is not from the paper. This is actually one of my own patients who I admitted on call. And I have permission to show you these slides. So this was an individual who came in on call with chest pain. And he was diagnosed with myocarditis. Now, interestingly, his echo was normal, but when we did his MRI, what we are seeing here, this is a T2 weighted sequence, and this white bit is swelling of the heart muscle, increased water content. This bit here is scarring of the heart muscle, and these are these parametric mapping techniques I've mentioned briefly, and what they're showing is diffuse inflammation and fibrosis before and after contrast injection. So that's all a little concerning. So loads of people have been infected. Now, what happens if you get reinfected? Well, unfortunately, the news is not good either. So this is a paper that looked at over 38,000 people that have got reinfection. And it showed that in addition to reinfection causing an increased risk of long COVID, it also causes a significantly increased risk of major adverse cardiac event outcomes. So cardiovascular complications, as well as neurological complications, kidney complications, bowel abnormalities, endocrine complications, hospitalization and death. So where are we now? We're 2.5 years into the pandemic. The cardiovascular risk that we know of and have documented so far shows that there is an increased risk after infection of acute coronary syndrome, MI, cardiomyopathy, cardiac arrest, heart failure, atrial fibrillation, atrial flutter, postural orthostatic tachycardia syndrome and dysautonomia, myocarditis, pericarditis, pulmonary embolus, deep venous thrombosis, stroke and TIA. But what is the potential outlook going forward? Well, we can't ever say for certain, but again, this is concerning. And the reason it is concerning is because we now know that COVID causes endothelial damage. The endothelium is the inner lining of our blood vessels. They become inflamed. That's due to partly direct viral invasion, partly inflammation due to cytokine release. Why is this important? Well, first of all, just to say there are lots of publications confirming endothelial dysfunction in COVID now, but why is it so concerning for us as cardiologists? It's concerning for two reasons. Firstly, endothelial damage is a major player and a key player in the development of long COVID, which Rhizia Pretorius is going to talk about later, so I'm not going to mention further. But also endothelial damage is the precursor event that causes the development of atherosclerosis. Now, atherosclerosis is the disease process in our blood vessels that causes cardiovascular disease, specifically heart attacks, angina, stroke, vascular dementia, and peripheral vascular disease. So that is worrying. So in summary, take-home messages is SARS-CoV-2 is not and never has been just a cold. There is clear evidence of cardiovascular and thrombotic adverse events in acute COVID. There is clear evidence of cardiovascular and thrombotic events in the medium term for the 2.5 years that we've studied this. But there is also evidence suggesting that we may have a bigger problem and that we may have a significant risk of longer-term cardiovascular complications mediated through endothelial dysfunction. And this needs urgent research. It needs urgent research because we need to know, is everybody who gets infected with COVID getting endothelial dysfunction? And if they are, is it healing or not? Because so far we have 605 million people in the world that have been infected with COVID globally. If the endothelial dysfunction is not healing by itself, I am very concerned that we are going to see a tsunami of cardiovascular complications, including heart attack, stroke, and vascular dementia over the next few decades. And I think removing all legal COVID restrictions, sorry, I don't know what's happened here.
Oh, we're just coming up at time, so.
Okay. I think this has come off. Yeah, here we go. Apologies. Removing all legal COVID restrictions before we understood the long-term health consequences may be our undoing. Unfortunately, we also know that reinfection worsens outcomes. And so there is really an urgent need to try and reduce reinfection on a global scale. Learning to live with COVID, knowing what we now know, cannot involve learning to accept reinfection every 6 months. Look, I have seen myself the torn endothelium floating around the bloodstreams of individuals who've been infected with COVID once or twice. I do not know what these blood vessels will look like after the 10th infection, and it worries me. So there is an urgent need for sensible discussions about public health mitigations to reduce the risk of reinfections, and the need for clean air most certainly has to be up there, particularly in schools, particularly in hospitals, and particularly in large indoor venues. There is also a very urgent need for funded research trials into cardiovascular risk going forward. But one of the good news is once we look at this, and we need to get this funded, and we absolutely have to release funds to do this, is that there are drugs already available that can potentially modify these risk factors and can potentially treat these risk factors and can potentially be used for primary prevention. I'm going to stop there. Thank you very much for your time.
Thank you so much, Dr. Ray. It's always good hearing from you. We are going to move on to a question and answer session. So if you could navigate over to the chat, if you have a question in mind, please submit your question. And I'm going to pull up our last three speakers, Professor Andrew, Dr. Ray Duncan, Professor Amitabh Banerjee. Thank you. And our host, Dr. Geraldine Hamilton.
Thank you, Katie, and thank you for incredibly wonderful yet horrifying talks. But we need to know this information, and I'm glad you guys are sharing it. So I have a question for Professor Irving. The brain effect that you described, do they get progressively worse? Do we know yet? Are they similar to what we see in other neurodegenerative diseases such as Alzheimer's, where patients get progressively worse and there's not a lot we can do, or do we have any data yet on that?
We're early in the game, but I mean it's likely that they're getting worse. It's some of them are getting worse and some are getting better. Okay, but we don't really know. But I mean the brain is depending on what happens in terms of damage, it doesn't repair. So some things can be compensated, but you're not going to repair. If you've got protein tangles forming in the brain during COVID, this is something that's going to show up years or decades later. But I mean, we're talking about having 30 and 40-year-olds with Parkinson's or Alzheimer's disease, and this is there's already a lot of anecdotal reports from neurologists saying that they have an uptick in the number of people they're seeing in their early 40s, let's say, with Parkinson's or early Alzheimer's. And so Parkinson's is a little bit more controversial. There's a beautiful paper that just came out on looking at the different variants and the different aspects of what's happening, at least psychiatrically, are dramatically different between the variants. And so it just shows you how complicated it's going to be. But I think probably some part of it will be progressive and get worse, and some part of it will level out and not be so bad. I don't know. I think Professor Duncan's talk was much more scary than mine.
Yeah, so I wanted to come to
You're scaring the hell out of me.
Dr. Duncan, so some of the very concerning cardiovascular and thrombotic effects that you described, we have a question from the audience: are those likely to also appear in children, and have you seen them in your own practice in pediatric cases?
So the first thing I would say is I am not a pediatric cardiologist. I am an adult cardiologist, but I do some work with the Long COVID Kids charity. It's a bit early to say yet. We are involved in sorting out a trial in children to look specifically at endothelial abnormalities in kids to see how prevalent they are, because we don't know that yet. There is some anecdotal evidence from colleagues of mine in Germany who have looked at a few children, suggesting rather concerningly that there may be some issues with endothelial dysfunction and similar pathophysiology to we're seeing in the adults with microclotting, etc., which is obviously very concerning, and which is why I'm a very big proponent of clean air in schools, because I do not want our kids to be repeatedly infected every 3 to 6 months with this illness and end up potentially, and we don't know this for certain, but with blood vessels of a 90-year-old by the time they're 40.
Yeah.
So, thank you, and we will look for the new research. And actually, to do with that, it seems from all of your presentations that we need to expedite the research to get more information. Dr. Banerjee, do you have any suggestions on how we could expedite that research? How can patients get involved in the clinical trials? How can we increase international collaboration to expedite the much needed data?
Yeah, I can tell you, as we're going through it. We've started our trial in various sites around England, and the barriers are similar to pre-COVID research. the delays in getting access to data, delays in approvals, and delays in getting sites started. And of course, we need to have more funds and more priority given to long COVID research, because acute COVID research was a public health priority and was prioritized above other health research. But by the time people woke up to long COVID, the same speed has not been given to pushing long COVID research through. So I think, as I say, funding and priority is important. I think also that we need to remember that even with more money and more resource, it does take time. And anybody who tells you they understand everything and have got the cure for this is selling you snake oil, because it is complicated. Even the studies that we've been doing observationally, we need to have data ongoing, 1 year, 2 years. We need to make sure we scan the different organs. We need to look at the brain. In our cover scan study, we couldn't comment on the brain because we scanned all the other organs. So we need to, as scientists, accept what we know and what we don't know. And as clinicians, we need to be pragmatic and get more done. But I think there are more and more trials starting. If, as a patient, I hope that we do more collaboration across countries so that everybody has access to those trials. Because one thing that has been a side effect of allowing infection to affect our health system so badly is that even within my research team, the research nurses and clinicians at the different sites, they've been affected by COVID and long COVID, and that's actually delaying our capacity to do this research. So at no stage and in no circumstance is a high infection rate good for anybody. It is a lose-lose-lose scenario, even for research. And I would love to study long COVID quickly and get more patients into my trials, but the ideal would be to not have patients to bring into trials. And we seem to be trying to create this disease burden.
Thank you. And we could take so many more questions, but we have to move on to our next session. Thank you so much, everybody. And Katie will introduce our next session. Thank you.
Thank you so much, speakers, and thank you, Dr. Hamilton, for running this session. We're going to be moving on to part 3 in one moment. We will be bringing up Professor Risa Pretorius.
Hello, everyone. Can you hear me?
Yes.
Today, I will be sharing with you our latest research on clotting pathologies, and I will spotlight our recent findings in COVID-19 and focus on long COVID. Here are just some of my collaborators and co-authors of data that is going to be presented here. More on our broader global collaborators later. I just wish to point out Professor Douglas Kell. He's from the University of Liverpool, and he is a systems biologist. And then the clinician, Dr. Jakolobscher, who's also in the audience. He is a cardiologist from Mediclinic Stellenbosch, and a whole team of researchers, also data scientists from Stellenbosch University. My lab and our collaborators from various labs over the world have been identifying inflammatory molecules in circulation that might be involved in and drive pathological clotting. And we have also focused our research endeavors on studying the effects of increased circulating inflammatory molecules and how they interact with cells of the hematological system. We focus in particular on platelets and red blood cells, as well as on the clotting protein, fibrinogen. We are also interested in identifying novel inflammatory molecules that might play a role in the persistent symptoms in long COVID. Focusing on platelets for a minute, here is a cartoon to show all the various receptors on platelets and their interactions with inflammatory molecules. They also bind to each other and to damaged endothelial cells. I am particularly interested in platelet signaling and the role in abnormal clotting. Platelets in circulation play a critical role in healthy blood clotting. However, they can become overstimulated and can drive pathological blood clotting if there are inflammatory molecules in circulation. This can also happen in the presence of viral infections, where platelets can act as important signaling entities. There is a complex relationship between receptors on platelets and endothelial cells, where these circulating biomarkers may bind to. As we now know, damaged endothelial cells and platelet hyperactivation are central pathologies in acute and long COVID. Our research group has shown these pathologies in both of these diseases in published papers. I just quickly want to focus on some science. If you focus your attention to the two cartoons shown in figure A, on the left is a healthy protein structure, which may have very many alpha coils and few beta sheets. However, in the presence of inflammation, oxidative stress, or circulating inflammatory molecules, these structure changes where the alpha coils untwist into beta sheets, as seen in A in the cartoon on the right. Previously, we added thrombin to plasma to create extensive fibrin clots. This process mimics clot formation in vivo. In plasma clots from healthy individuals, these clots have more alpha coils, with the ultrastructure shown in figure B. These clots look like a net and is typically formed, for example, when you cut yourself. Various inflammatory conditions, including cardiovascular disease and diabetes, have a clot structure as seen in figure C, where the fibrin net is plate-like and dense due to fibrinogen that have been exposed to circulating inflammatory molecules. Damaged fibrinogen molecules that clot is in this manner, clots in an anomalous manner. Already in May 2020, we, together with our clinical collaborator, Dr. Ilakio Loubser, found significant coagulation and platelet pathology in acute COVID ICU patients. It was then that we discovered that fibrinogen formed these spontaneous microclots in circulation. Here you can see scanning electron microscopy micrographs where these fibrin deposits attach to red blood cells. This is simply in a blood smear, nothing added. So early in 2021, we turned our attention to long COVID. We looked at blood samples from patients and soon realized that there are persistent microclots and widespread endothelial and platelet dysfunction in these patients too. These pathologies may be central in causing the widespread symptoms in these patients and may lead to tissue hypoxia. We initiated a South African long COVID registry in 2021. And here are just some of the symptoms noted in these long COVID patients, very much similar to that was reported globally over the past few months. And here's brain fog, concentration issues, forgetfulness, constant fatigue. Those are the symptoms we also report in South Africa. Most prevalent comorbidities are high blood pressure, high cholesterol, rheumatoid arthritis, and type 2 diabetes. We also looked at blood samples from these patients and compared results to samples from healthy individuals. On the left, you can see platelets from healthy patients, and on the right, platelets from patients suffering from long COVID. Large platelet clumps can be seen. We also planned an experiment where we looked at proteomics, where we find proteins trapped inside these microclots, and we compared healthy plasma versus type 2 diabetes, acute COVID and long COVID. We added the diabetes samples as we know that people suffering from diabetes are more prone to severe COVID symptoms. For these proteomics analysis, we prepared plasma and we followed a first trypsin digestion step. To our surprise, we found a visible deposit at the bottom of the tube in acute COVID as well as long COVID, but not in the diabetes and also not in control samples. Plasma proteins, therefore, were fully digested in controls and diabetes, suggesting that trypsin could degrade all or at least in most of the proteins in the controls and the diabetes. For proteomics, we then filtered the sample and we also digested it further and then we could indeed solubilize the undigested pellets. When we viewed the unfiltered supernatant after the first digestion step using fluorescent microscopy, we noted that patients with type 2 diabetes and plasma from healthy patients digested fully, and we couldn't find any signal. The signal we are referring to is the green signal. And you could see that in the micrographs on the top left. In contrast, there were still numerous microclots in plasma from patients with both acute COVID and long COVID. After the second digestion step, we then could digest the microclots and we searched for molecules. We detected various inflammatory molecules that were substantially increased inside the microclots of the COVID and acute COVID and the long COVID versus the equivalent volume of the fluid in the controls. Of particular interest was a substantial increase of alpha-2 antiplasmin, fibrinogen trains, as well as von Willebrand factor. And here's just a diagram for the clotting cascade, and not going into much detail, but look at where alpha-2 antiplasmin has an effect. It prevents clot breakdown. So the lack of breakdown of these persistent clots may have significant clinical value. Here is a simplified diagram of our take on explaining clot formation and then also breakdown. And if you look at this diagram, during acute COVID-19, spike protein induces the microclots that are more resistant to clot breakdown, as we have discovered. But in some individuals, during the recovery process, healthy fibrinolysis will happen as it should, and these individuals will then return to health. However, in some individuals, we now know 10 to 30%, healthy fibrinolysis will not happen. A lack of breakdown of fibrinolysis in long-COVID patients may result in a persistent failed fibrinolytic system. We just completed a larger proteomic study where we looked at 100 long COVID and 30 controls. The research is in press in cardiovascular diabetology. Some of our most noteworthy findings include a downregulation of the molecule kallikrein, an upregulation of platelet factor 4, once again von Willebrand factor, and marginal upregulation of, again, alpha-2 antiplasmin. If you return to the clotting pathway diagram, you can see where these molecules play a significant role, and all points to decreased fibrinolysis and eventually fibrinolytic failure. We also found a significant presence of antibodies this time entrapped inside the microclots when we searched for it. I just wish to return to some of the latest research from other groups. Here is a document from the US government where microclot presence, viral persistence, autoantibodies were recognized as central pathologies to look into in finding answers in long-COVID. And this is really important. I'm also happy to report our work was featured in Science in June, as well as recently featured in Nature. And to conclude, just the way forward, together with our team of international collaborators, we will report back soon on more laboratory results for long COVID. Researchers at Sheffield Hallam, as well as University of Manchester, have confirmed microclots in long COVID patients and could correlate the degree of microclot presence to disease severity. Dr. Benita Khan and Dr. Ray Duncan, which talked before me, are involved here. We desperately need clinical trials on treatment that combine prevention of microclot formation and platelet hyperactivation. Treating only the one and not the other will perpetuate vascular damage. And just my final comment to report from the WHO panel meeting earlier this week, where I was a panel member. We are currently formulating the case definition for long COVID in children. Thank you for allowing me to share our research with you.
Thank you so much, Professor Risa. I just want to mention that Professor is a researcher and a distinguished professor and chair of the Department of Physiological Science at the Stellenbosch University in South Africa. So thank you so much for joining us today. We're going to be hearing now from Carmen Shaban-Bogan. I'm going to have you come up here.
Yes, hello. Good evening from Germany, or good afternoon to you.
Thank you. Let me introduce you. So Professor Carmen Schoenbenbogen is a hematoncologist and professor of clinical immunology at the Institute of Medical Immunology at Charité Berlin. She is a co-founder of the cost-funded European Network for MECFS Euromen, the Charity Fatigue Center, and the Post-COVID Network. She has co-authored more than 200 peer-reviewed papers with a focus on MECFS, T-cell immunology, and cancer vaccines. Thank you so much, Professor.
Yeah, thank you for this invitation. It's a pleasure to present you our recent studies on post-COVID MECFS. And we actually at Charité have a long-standing experience in post-infectious MECFS. And more recently, we study post-COVID patients clinically and do research within our post-COVID network. And I'm going to talk about our observational study to analyze if MECFS is part of the post-COVID syndrome and one of the sub-studies on the potential role of G-protein-coupled receptor autoantibodies in post-COVID syndrome. So patients with post-COVID syndrome present with a plethora of symptoms, many of them resembling MECFS or chronic fatigue syndrome. And among them, the key symptoms of fatigue, of exertional intolerance, and brain fog. So we performed prospective observational studies, seeing patients presenting with these three key symptoms and analyzing these patients in a team of interdisciplinary physicians for potential comorbidities, assessing symptom severities, doing various laboratory studies, and looked for the presence of MECFS using the Canadian consensus criteria. And the study was just published last week in Nature Communications. And the main finding of the studies is that COVID can indeed trigger MECFS, very similar to MECFS we have known for a long time, triggered by other infections like EBV. And it's mostly in patients following so-called mild COVID. However, looking at these criteria of fatigue and exertion intolerance, we could define another post-COVID subset with very similar symptoms. And the main difference is that they had a shorter post-exertional malaise. For those who are not familiar with MECFS, that describes that even minor exertion can lead to disease aggravation lasting per definition in MECFS at least until the next day. And in this other subset, patients reported on having exertion intolerance as well, but this usually was shorter and they usually recovered within the same day. So this patient group were younger people with a predominance of females, and they were quite sick. So 50% of these patients were unable to work. The first time we saw these patients was at month 6 after infection. We've been following these patients now for more than 2 years, and we couldn't actually change the disease course with the symptomatic treatment. So many of them are still very sick, and the most severe of them are bedridden, and the presentation and the disease course is very similar to our other post-infectious MECFS patients. So coming to the role of the G-protein-coupled receptor autoantibodies, we have been interested in these antibodies in MECFS for many years. They are fascinating because they are natural regulatory antibodies, so we all do have them, and most of them are agonistic, so they stimulate the receptors they target. We know now that they are dysregulated in many diseases. And if we have altered levels, this may either indicate a homeostatic response to receptor activation or indicate autoantibody dysfunction. In ME/CFS, we know that beta-2 receptor adrenergic antibodies are elevated in a subset and are dysfunctional. We did a recent study showing that they correlate well with severity of symptoms, and first trials also provides evidence that autoantibody depletion is effective in ME/CFS and post-COVID syndrome and leads to a sustained drop of beta-2 adrenergic receptor antibodies. So the study we performed in the post-COVID patients, and we just published this study as well in Frontiers Immunology, is straightforward. So we analyzed levels of a total of 20 G protein coupled receptor antibodies in these two cohorts of post-COVID symptom patients, and in healthy controls, those who had COVID but completely recovered and those who never had COVID. And these antibodies do target various receptors, and to cut it short, the main function of these receptors is to control the cardiovascular symptom and to control inflammatory pathways. So what did we see? We found that several of these antibodies are dysregulated, so that network connections were altered. Some of these antibodies were actually lower in post-COVID patients. And the most striking finding is that we found that they do correlate with symptom severity. This is depicted here in this figure for fatigue. And what you see here is the correlation coefficient of the severity of fatigue with the level of these antibodies we analyzed. And in dark, the dark columns represent the patients fulfilling the Canadian criteria for ME/CFS, and the gray are the patients not fulfilling the criteria. So we found a correlation of several of these antibodies, including adrenergic antibodies and muscarine acetylcholine antibody receptors, but also angiotensin, with the severity of fatigue. Looking into cognitive impairment, we had a different picture. Here only antibodies to PAH and CX3 receptor and stabilin did correlate with severity of cognitive impairment, pointing probably to an inflammatory mechanism. And again, only in those who have the full clinical picture of ME/CFS, but not in the others. And most strikingly is many of the post-COVID patients actually present with Raynaud symptoms. And here we found a strong correlation in those, again, with the ME/CFS phenotype, and the strongest was for the beta-2 receptor antibody, which we have been studying for a while in post-infectious ME/CFS and have evidence already that it's impaired in its function. So we did also some studies on endothelial function in these patients, and to sum up our studies, which are also published already, is that in these young patients following 6 months after COVID, we have already evidence for endothelial dysfunction by a technique, the endoPET analysis, where we analyze the function of the capillaries in the fingers. We find various endothelial biomarkers altered. Most remarkably is that endothelin levels are upregulated in both of these cohorts, indicating hypoperfusion of endothelial vessels. And we also could observe that sera from these patients does impair nitric oxide mediated pathways when studying them in vitro in endothelial cells. So to sum up our findings, we know that ME/CFS is part of the post-COVID syndrome using the strict Canadian consensus criteria. G protein coupled receptor antibodies are associated with symptom severity in post-COVID ME/CFS, and our data point to endothelial dysfunction and hypoperfusion as a pathomechanism in a post-COVID ME/CFS. This slide is to acknowledge my co-workers and our funding. Antibodies were determined with the assays from cell trend. And this is our fatigue center at Charité, where we have a site we provide a lot of information for patients and physicians, and also have regularly educations. Thank you.
Well, thank you so much, Professor Carmen Schenbenbogen. That was very informative. Next up, we have Professor Diane Griffin. So I'm going to bring up Professor Diane up to the stage. Let's see. Here we go. One moment, I'm going to introduce you. All right. Professor Diane Griffin is from the University Distinguished Service Professor in the Department of Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on the pathogenesis of RNA virus infections to understand viral and host determinants of outcome, recovery, and protection from infection. She has had a long-term interest in the role of viral RNA persistence after apparent recovery from infection. Thank you so much, Dr. Griffin. I'll turn it over to you now.
Okay, well, thank you and for the opportunity. I'm going to give a perspective on RNA persistence and recovery from acute RNA virus infections. And first, some examples of studies that we've done, and then how it may relate and likely relates, we think, to long COVID and the complications after SARS-CoV-2 infection. So we've studied the first observation that RNA was not cleared after what was apparently acute virus infection was in studying encephalitis with alpha viruses, where the target cells are neurons. And so these are long-lived cells that obviously the host can afford to do without. So recovery from virus infection of these types of cells, here are seen motor neurons infected with alpha virus, require the immune system to have a non-cytolytic approach to controlling virus infections. And we found that in the red here is the period of time during which you can recover infectious virus. So basically this infection is cleared very rapidly from the brain of, these are mice that are infected with this virus. However, if you look at the RNA for the virus, you find that it's cleared very slowly and actually is not completely cleared, so that it's present for the life of the animal. Now, we looked at infectious virus. We identified these non-cytolytic approaches that the immune system uses to clear infection, so antibody and interferon gamma. And so the infected neurons survive from infection, and then are the source then of this RNA that's persistent for long periods of time. Well, a consequence of that, if you look overall, you see infection of the neurons with infectious virus being produced, but that gets shut off fairly fast with the innate response, plus T cells that are making interferon gamma and B cells that are making antibody that infiltrate the nervous system to control and shut down production of infectious virus, but do not kill the neuron and allow the neuron to remain, but we have persistent viral RNA. So that means that there's actually a requirement or a need for long-term control. And so what you also find in the brains of these mice is then long-term residence of both B cells making antibody and T cells making interferon gamma that we assume are preventing the reactivation of this infection and progressive disease. Now, that was all with neurons, and neurons are long-lived cells, as I say, and essential and not replaceable, not easily replaceable, that's for sure. So we were very surprised to, and did not think that this would be true of other acute virus infections. So this is the case of measles, which I think is most relevant to thinking about SARS-CoV-2 and long COVID. So in this case, these sites of virus replication are in lymphocytes and epithelial cells, all cells that can be replaced. They're not neurons. And so the blue is the period of time during which you can find infectious virus after infection. It's a respiratory infection that becomes systemic. The onset of the rash is the adaptive immune response. You see a clearance, and you could no longer recover infectious virus after about 2 weeks. But that's not true for RNA. You could continue to find viral RNA in peripheral blood mononuclear cells for months after apparent recovery from disease. But if you look in lymph nodes, you can find viral RNA there for many more, long after it's apparently cleared from the blood and from peripheral blood mononuclear cells. And we don't actually know how long it takes to clear that infection. But what's relevant for our current discussion is the fact that if you look during this period of time at what's going on with the immune response after apparent recovery from the acute infection, there's a lot going on. So early on, you find interferon gamma T cells. Later, you find these IL-17 positive T cells. You see increasing appearance of cells that are important for making antibody. You see maturation of antibody. So this is a very active immunologic response to infection that's occurring, as I say, months after apparent recovery from the infection. And for measles, it's also relevant that it's an immunosuppressive disease. And so this persistence of RNA may well be very important for the alterations of immune responses that are seen for, again, years after recovery from measles. So I'd just like to point out that even though we think of virus infections killing the cells if the immune response doesn't, actually in vivo, it's very common for cells to survive. And there are a lot of mechanisms that are both the viral mechanisms for establishing persistence and for preventing cell death, as well as host mechanisms. Non-cytokinin clearance, we've already mentioned with respect to alpha viruses, but the sites of virus replication often are infiltrated with immunosuppressive cells and responses. And the virus has many ways to dampen the amount of virus that's being made and the replication in order, we think, to actually avoid killing this infected cell. So there's lots of examples of acute RNA virus infections where there are late complications. For measles, subacute sclerosing panencephalitis, which is a nervous system disease, occurs 8 or 10 years later. We think that RNA is driving the development of lifelong protective immunity. We're in the process of looking at that. But I'll just point out that for Ebola virus, there's late transmission occurs, recurrent uveitis, encephalitis. There's a post-viral syndrome that is very profound after people have, as I say, apparently recovered from the acute infection, cardiomyopathy with enteroviruses, and then the long COVID of SARS-CoV-2. So what evidence do we have that persistent RNA may be driving some of the complications that are seen or the symptoms that are seen? Well, there's certainly detection of RNA in a number of sites. Respiratory secretions and stool are the most commonly examined, and where that's been found. And certainly there's one study at least that reports RNA and protein in a subset of blood monocytes that also is very prolonged. And autopsy studies have shown widespread detection of RNA in many tissues. Of course, those are people who died rather than long COVID, but it raises the possibility that this has happened in more commonly. And so we're focusing right now on seeing if there is any evidence for prolonged virus-specific immune activation that occurs in association with people who have long COVID versus those who don't, basically to see if you could get evidence that RNA is driving any of these symptoms. So that's a summary of, I think that's the last slide, yes. So in conclusion, basically, persistence of viral RNA after acute infections is common. I personally think that it's the rule that it usually occurs. Both viral and host mechanisms foster suppression of production of infectious virus and survival of infected cells. And there are consequences that are varied and host and virus dependent, depends on where this is happening, characteristics of the virus itself. But we know that cellular dysfunction can be progressive. Persistent cytokine chemokine production is possible. Long-term recurrent stimulation of adaptive immune responses, late reactivation of infectious virus production, and unexpected transmission are all potential consequences. So I think that it certainly is conceptually possible that long COVID is being driven, although with the various pathogenic mechanisms may be related to the persistence of viral RNA. Thank you. Quit sharing here. Okay.
All right. Thank you so much, Dr. Griffin. We will now be moving to the question and answer session. So I'm going to be bringing on to the stage, well, Diane, you can stay.
Okay, I will.
Professor Carmen Scheibenbogen and Ricia Pretorius. And our moderator, Dr. Geraldine Hamilton.
Okay, let's get started. We have several questions for the speakers. Thank you for your talks again. Professor Pretorius, your data seems to clearly indicate the impact on platelets. These are cells in our blood that are very important in the regulation of blood clotting, and they've been implicated in inflammation and so forth. Can you relate for us how this impact on platelet function relates to some of the brain and cardiac effects that we heard from speakers earlier today?
Platelets, they are central when you look at blood clotting, and they also form complexes within cells when they're damaged, and they can form complexes with immune cells as well as endothelial cells. We believe that in long COVID and acute COVID, but obviously we're talking about long COVID here, there are widespread systemic inflammation of the endothelial layers. And if that happens, the platelets will react to these damaged cells. Endothelial cells, damaged endothelial cells, will produce molecules, inflammatory molecules in cells. Platelets themselves are potent signaling entities. If we have this widespread endothelial damage, it will not only affect the periphery, but it could possibly affect the whole system, the whole vascular system, which also has an impact in the brain. And we know that LPS, which molecules produced by various bacterial wall products, they can damage the blood-brain barrier. And then damage can happen via the blood-brain barrier, which is nothing else but a vasculature. So platelets are central in driving vascular damage as well as pathological blood clotting, which involves the plasma proteins. You are muted.
You must be muted.
I'm muted. It had to happen at least once during the whole event, of course. The next question is for Professor Scheibenbogen. I don't think I pronounced that right. Please do correct me. The question is regarding the G protein coupled receptors that you mentioned. You stated that these antibodies that are associated with symptom severity for long COVID. Do you think they offer the potential for development of a biomarker, i.e. things we can easily measure in the blood? Can they be measured in a clinical setting right now? And could they offer a possibility for therapeutic development, which we realize even if they do, it would take a long time, but are these feasible?
Yeah, thanks for this important question, and you perfectly pronounced my name. Actually, we tested in the study the diagnostic suitability, and by combining several antibodies, we can reach a quite good diagnostic accuracy. But as this was only a small cohort, we definitely need to analyze larger cohorts to see if this holds true before we can think about developing this as a diagnostic test. Regarding therapy, we in the past did already trials targeting autoantibodies in post-infectious ME/CFS. So we did trials with high-dose IgG and with immunoabsorption. That's a technique with which you can wash out all immunoglobulins. In patients with ME/CFS, we observed a rapid symptom improvement using this technique. These were, however, only 2 small studies, and the planned larger study we wanted to perform was in 2020. And then the pandemic came and we had to postpone it. But now we started again with immunoabsorption, and we currently do a first trial in post-COVID ME/CFS, and we hope to have first cohort studied end of this year, and this will tell us probably very rapidly which role these autoantibodies or autoantibodies in general do play in these patients, because immunoabsorption usually leads to rapid improvement of disease. Although it's usually not sustained, it would be important to see if we are right with our concept that autoantibodies do play a major role, especially in the subset of post-COVID patients fulfilling ME/CFS criteria.
Thank you. And my next question is for Professor Griffin. So you beautifully described the potential for viral RNA persistence in cells. We see evidence in other viruses, and this, you suggest that this may be happening too with SARS-CoV-2. I'd like for you to describe how you think that is then linking to some of the inflammatory effects we see with long COVID and potential things that a patient could experience that may reactivate an infection as well.
Well, I think that the fact that the RNA is around, and although there's been controversy over whether the actual virus could continue to could reactivate and become infectious again, I think that most of the evidence is that protein is being made, and that's what the immune system is going to be responding to. And so both the production of and stimulation of immune responses that can be local. I think one of the things that we don't really have a good handle on for long COVID and the potential for a viral RNA to be driving many of the symptoms, which can include the abnormalities with the endothelial cells and platelets, and actually as a scenario for producing autoantibodies because of the dysregulation of the immune response that that's likely to be happening in local tissue, and people have looked mainly in the respiratory tract, which makes sense. But I think there's a lot of evidence that this is a systemic disease in many people, and the sites where these the stimulation is ongoing, I think, is not clear, and that's hard if you're studying people who are alive and having particular symptoms. To sample lots of sites is difficult. I mean, it's prohibitive. So I think we have to look for other evidence that that's the ongoing process, and it would lead to the possibility that antivirals would be useful late. I don't know those things, but I think there are trials, or there are likely to be trials to at least look at that. But right now, finding some evidence that this is a likely driver for many of the late consequences, I think, is the important thing. And I'll emphasize the need for research.
Yes, indeed, and funding for that.
And funding, right,
Funding
absolutely, right.
All right, thank you very much, everybody, and we will be moving on to our next session. Thank you.
Thank you so much, Dr. Geraldine Hamilton, for hosting that Q&A, and for the professors and doctors coming in for that. So next up, we have Maddie Heino. We are so pleased to have you here today. I'm going to go ahead and put you on the big screen here for everyone and say a little bit about you. So Dr. Maddie Heino is a social psychologist studying societal crisis, resilience, and pandemics, with a focus on human behavior, change processes, and complex systems. In addition to research, he also works with providing practical behavioral science policy advice on both national and local levels. All right, thank you so much, Maddie.
Yeah, hi, welcome everyone. So you've had a long day already, right? So let me share my screen. Here we go. Okay, so I'm going to talk a little about perhaps something a bit different from what you've seen so far. So my perspective is sort of on a bit of a coarser scale. So the only thing I know about COVID immunology is that yeah, it's not good to get COVID. So I'm going to talk a little about how social change in general tends to happen, and how behaviors in social systems can and do change. So in order for any behavior to take place, you basically need to have three conditions in place. So you need to have some capability to do the behavior, you need to have some motivation to do the behavior, and you need to have the opportunity to do the behavior. And at this point, someone is going, oh, but if someone puts a gun into my head, then I'm not motivated to do it. But yeah, sure. You are motivated to do it. Gun on your head is a motivation. It's not a very long-lasting motivation, because once someone removes the threat of punishment, then you usually stop performing the behavior that you were forced to do. So we call that the extrinsic motivation that's derived from external factors, and not intrinsic motivation, which would be due to feeling a sense of internal motivation, be it from pleasure or a behavior being aligned with your ideals or values and so forth. So in short, for example, in order to avoid getting COVID, you would need to know how to avoid getting COVID, you would need to want to avoid getting COVID, and you would have to have the physical and social opportunities to avoid getting COVID. And but this looked very within individual factors at the first blush, and we tend to, at least in the Western sphere, we often tend to look at them from a within individual perspective. But it doesn't take a lot of thinking or reflection when you realize that for any behavior, nobody really knows everything. So we rely on other people a lot. For knowledge, and we take much from other people, and we also share our knowledge with other people, so that we wouldn't have to be overwhelmed by all the capabilities in the world that we need to survive in the modern environment. And also much of motivation comes from observing others around us. So what we all constantly do is we look at what other people are doing, and often implicitly we derive from that a judgment about whether this behavior is sensible or not, or safe or not, and so forth. And the physical and social opportunities to do something, so resources, social approval, and so forth, they always, of course, involve other people. So just to put it shortly, is that we are mentally and physically integrated with the people around us. So we are not as individualistic as we would often like to think about being sort of islands in a vast sea. And this sort of implies that we need to find ways to work with the people in our community, not against them, and do that without risking ostracism. And I'll come back to that a bit later. The next thing I wanted to talk about was collective illusions. So this is a term that Todd Rose has done a great service in popularizing in his book of the same name that came out this year. So a collective illusion is the situation where the majority of people in a group end up doing something that none of them privately agree with, because everyone just incorrectly infers that the group wants something that they privately don't. And I'll give an example of this. So you have a bunch of people here sitting on a table, maybe it's a workplace, and there's this one guy, everyone knows he's super smart because he has a big head. And so he says, everyone should just return to work on site. After all, the pandemic is over. And I think everyone kind of gets quiet and no one says anything. And so this guy thinks, oh, well, no one's saying really anything. So I guess they agree. And this is, of course, this is not a problem. It becomes a problem when everyone actually thinks the same way. And so now all of these people think that this is the group's consensus, and they may not have any willingness to start questioning their idea. And we are actually really bad at deriving group consensus from implicit cues. So it's okay to disagree with our community's views, but we shouldn't just assume what those views are. And we can't really resolve any issues on the societal level if we don't understand what the issues actually are. If we are just thinking that, oh, it's just me who's crazy and everyone else thinks something else. And then a third and last idea that I wanted to bring here is is an idea about how change happens. So we can have gradual change or linear change, and we can have abrupt change or non-linear change, if you wish. So here we have the acceptance of an idea in a society. So the more time goes on, the more the acceptance grows. And so this happens sort of steadily and nicely. And so if we need, we have sort of time to adapt, and we can predict quite nicely, okay, so what's going to happen next, and so we have time to make adaptations and reparations if something goes wrong. But often what happens in these sorts of social systems is that the ideas actually spread like this, so that first you have nothing happening, and then suddenly all the change happens almost at once. And a way to understand why this happens in this way is that is via the metaphor of attractor landscape. So there's a mathematical underpinning that I'm using this here just as a framework of understanding this process. So we have this resembles a society with two states. So these valleys here are states and or attractors, and so this attractor means that the long COVID requires action, and this is that long COVID is not an issue. So most of society thinks that long COVID isn't an issue, and this ball represents the state of the society at this particular point of time. And what can happen if we sort of if we go to this situation where we don't reveal our true preferences and we don't question the group's consensus, but we just go along with it, is often that the society seems to sit still on the same spot, and nothing really seems to be happening. But what's bubbling underneath is that people are starting to have like private conversations, and then they're wondering, oh, so it's not me who's crazy and everyone else is not, but it's like it's our group who is crazy. And then this sort of talk can start increasing and bubbling under until the society reaches a point where suddenly the public opinion shifts to after a very small push, it can shift to a new state where, for example, long COVID is. And same thing can be applied to the level of the big-headed guy. So you talk to him every day, and nothing much seems to be happening. But at some level, he's starting to question his own beliefs, and at some point, just one extra bit of evidence can push him to this other perspective. So these rigid belief systems can be destabilized with the right kind of continuous communication between group members. And when I say right kind, I mean that it's the kind of communication that doesn't put everyone to make them dig deeper bunkers for their favorite opinions, but it's actually preserving trust. It's continuous, and it's flavored by respectful curiosity. And so one way to do this is that if you consider the same situation as earlier, but now this person kind of says that well, expresses uncertainty. So says that they haven't made up their mind about this, and that there is on the one hand it's this, and on the other hand it's that, because very often we see these things and these opinions, they are very black and white, so very dichotomous, and exposing the dichotomies and trying to bring more nuance into them and expressing uncertainty is something that seldom you risk ostracism from a group or a community if you say that you haven't made up your mind yet. So there are a few things we can do alone, and we can work with our communities. Ingrained beliefs can lead to gradual change, and we can break these collective illusions by voicing uncertainty. And that's all I had to say for now.
All right, wonderful. Thank you so much, Dr. Maddie Heino, for that presentation. Jason has dropped the questions for the form questionnaire is right in the chat. So please drop your questions there. We're going to be moving to Dr. Cecile Phillip.
Hi.
Hi.
Can you hear me?
It's a little bit quiet. Let me spotlight you.
Okay, can you hear me well, or I put my headphone on?
Should I?
Is it better?
Oh, it's much better. Sure. So let me introduce
Okay,
you.
so go for that.
Yeah, Dr. Cecile Philippe holds a doctorate in economics from Paris Dauphine University and a diploma in advanced studies in business management in developing countries. She created the Institut Économique Molinari in 2003 and has headed the institute since then. She writes extensively on COVID and the economics and co-authored reports on the effectiveness of public policies for fighting the pandemic. So thank you so much, Dr. Cecile, for being with us tonight.
Thanks, Katie. I'm so glad to be here. Thank you for inviting me. And I'm going to try to share the one slide I want to show you tonight. Can you see it? Let me see.
Yeah, we can see it.
Okay. No, it's not going to work for me in that way. Okay.
It looks
so that I can...
perfect.
Okay, so actually, that slide summarizes what I want to tell you tonight. So above the sea level, you have what we've seen, death and hospitalization. And under the sea level, the implication of COVID, and they are absolutely enormous on the economy and society. And this is what I want to tell you. And maybe I'm not going to share my screen too long, because actually it's that one slide. But the thing is that the invisible is so huge, and I'm going to explain why. What we need to understand is that long COVID is the symptom that COVID is a societal problem that needs to be dealt with. And the reason why is because it is destroying the trust in the system we are living in. This system, it's the capitalist system, we like it or not, but this is the system we are living in. And actually, COVID destroys us, so we destroys it. And the reason why it does destroy it is because it works because the system works on trust. You know, the system in which we deal with each other, it's based on division of labor. We all specialize in something, in one thing or the other, and we do exchanges, transactions. And it's only because we trust in the power of money and in the fact that if I give you something and you give me in exchange money, I will be able to continue my life and do some other exchanges. We can work all together and get the reward of cooperation. But wave after wave, COVID is eroding this trust, and actually it's a disastrous thing, because without that trust in the system, it is not working properly. It dysfunction, and then in economics we speak about recession, or we speak about destruction of demand. But in the end, we are not able to provide. The system is not able to provide as much as it was able to do before. And a key system, a key institution in the whole place are labor markets. And those labor markets works in the following way. You as a consumer, when you buy something, you provide the cash flow for the entire system, for all the players, for the workers first and their family, for the businesses, and also for the state. And if the labor market starts to dysfunction because of illness, and what we've heard today shows that actually the problem is really real, then we face disruption and destruction of the power to cure some of our ailments. And this is showing now in the data. It's true that the data are still very scarce on long COVID and the labor market, but in those markets where actually very, very often you have full employment, the UK market, the US market, tensions are very easy to feel, and they are felt. And for instance, the Brookings Institution in January 2022 put out the number that 15% of the unfilled jobs were due to long COVID. Then a few months later, you had the Bank of England showing out, stating that there were 300,000 people missing on the labor market due to illness, and actually mentioning COVID and long COVID in the short term and long COVID in the longer term as the main cause of this situation. In France, for instance, where we did not have full employment for decades, it's much difficult to see. We need to find other signals, but they do exist. We see since the beginning of 2022 that daily benefits are really increasing fast and in very huge importance. So a bit early in this talk, I'm going to tell you what are the takeaway, what are the main implications. If you want to think about long COVID, you need to think that actually long COVID helps tax evasion. If you have less people working, you have less taxes paid in order to finance public services just at the time when they are in so much need, be they a healthcare system or pension system. In France, for instance, 95% of what people get when they retire comes from people working today. So when you have less people in the working force, it becomes really a societal problem. Then you need to think that, of course, long COVID destroy wealth for the people who can't work anymore and cannot meet ends. Then long COVID competes with other businesses in taking out people, taking out labor from the pool. And for businesses, this will, and for some of them, it's already a nightmare because when you have, first of all, when you can't find people, you are in difficulties to proceed with your company. And then when your labor force starts being sick, you face disruption, longer time production. And then it comes even to the fact that you might not find the material and the resources you need once the situation propagates to the entire economy, and other businesses cannot provide you with what you need as means of production. Then, of course, long COVID feeds inequality. It's been said here, between men and women, between white and Hispanos, for instance, between people having the chance to have good insurance and self-employed, etc., etc. Then long COVID consume talented people, and that's a very important issue, because in economics, we believe that there is this 80-20% rule, meaning that the most talented contribute to economic growth in a disproportionate way. And actually, so far, it looks like the most talented might be also the most healthy, and maybe they have been in some way protected from long COVID. But as infection and reinfection happen, it might not be the case that it's going to be sustainable. And if it is the case, at the societal level, it's a problem, because actually they contribute a lot to economic growth. It could be between 20 and 40% of the growth since the 60s in the US, which come from actually a better allocation of talents. And so when you look at all these implications, you really realize that long COVID is a very, very big issue at the societal level, besides the cruelty of the illness for those who are already suffering of it. And if it's difficult to capture the phenomena by one number, actually, we are trying right now to evaluate the impact of long COVID, and some have tried. At least one economist has tried to evaluate what could be the cost of long COVID. His name is David Cutler at the Harvard University, and he comes with the number of $3.7 trillion, which is actually the equivalent of the cost of the recession, of the recent recession. So the conclusion is that actually, with such huge number and with so many societal implications, there is not really any limit to the investment we can take as society to take protective measures. And I stop here.
Thank you so much, Dr. Cecile Philip. That was very informative. It is important to understand the serious economic repercussions of letting this pandemic go on and on. Thank you so much. Next up, we're going to see Yanir. Just need to add you here. Thank you, Cecile. All right, introducing here Professor Yanir Baryam, President of New England Complex Systems Institute and co-founder of the World Health Network. All right, Yanir, I will turn it over to you.
Can you hear me all right?
Very well.
Thank you. So what have we learned, or what have we been learning about long COVID? The first thing should be to answer questions that try to look for reasons that it isn't so bad. Maybe it's in your mind. No, it's a real biological damage. Maybe it's rare. No, it affects tens of percents of people who are infected, and even those without symptoms have organ damage and acute events like heart attacks and strokes, as well as cognitive loss. Maybe it goes away. No, it lasts for years. Some get better, most do not get completely well. Maybe vaccination stops it. No, it reduces somewhat the effects, but is not a solution. Maybe getting infected protects you has been one of the ideas. Actually, repeated infections are similar, if not worse than the first, leading to long COVID symptoms and acute events that are associated with organ damage. Maybe we have treatments. No, similar chronic diseases don't have treatments. There are some things we can do, but we can't do much at this time, and we are just starting substantial research and can't expect results soon. Maybe the economy will be okay. No, surely not. Disability of people, reduction in cognitive capabilities, including but not limited to experts, are all harmful and have significant effects on the labor market and on the supply chain. So long COVID is bad, but what can we do? And the main thing, which has been said multiple times, is that what remains is to avoid being infected. If you have been infected before, whether or not you have long COVID, the main thing is to avoid being reinfected. This gives the best chance of both not getting long COVID and getting better if you have it. As Ray Duncan said earlier, there is no such thing as mild COVID. And this means that it causes damage. And the damage it causes is both direct damage and potential for other damage, including through disabling the immune system that protects us from diseases, cancers, and other harms. The consequences of immune deficiency are constantly being referred to these days, but we should recognize that we have immune deficiency that is now widespread in the population. So most importantly, the question that we should answer is whether we have the ability to prevent infection. And the answer is we do. There are 5 pillars of prevention: ventilation and HEPA air purifying for clean air, masking, testing, social distancing, and vaccination. Each of these has multiple levels of action. This means that there are many ways to do more to protect ourselves and the people we love from getting infected. This is not a biological problem, it is a technology adoption challenge that we as individuals and as a society can decide to win. For example, we can increase ventilation to 5 to 10-fold per hour, which is the standard that has been set for air pollution. Or we can do it at a higher level to better prevent transmission. Or we can even use directed airflow so that individuals have air to breathe that is clean. We can wear N95 masks, or we can go one step higher and wear elastomeric respirators, or we can use PAPRs, powered air purifying respirators. The best, of course, is to do two-way masking or other measures, other PAPRs or respirators, so that everyone in the space is masking, which multiplies the effect. We can do testing. We can test a couple of times a week, or we can test daily, which our calculations say can itself control transmission. Or we can even test just before we meet people. PCR or LAMP tests are much better than antigen lateral flow tests, and we can and should make them be low cost and easily available so that we can test before we meet people to have the best effects. We can also do different levels of social distancing. Yes, stringent lockdowns are the highest level, but we can also focus on limiting as much as possible in-person meetings and make sure that any meetings have the best ventilation, masking, and testing possible. Finally, we are just now developing next levels of vaccines, but how effectively we use them, along with other preventive measures, will impact the effectiveness of all the measures. The better we do at preventing transmission, the fewer mutations there will be, and the less we will have new variants to undermine the vaccines. The power of vaccines is directly related to limiting the transmission itself. So what we have learned about long COVID is that the choice considers to be in front of us, to choose health over disease by prevention, both for those we love and for ourselves. Thank you.
Thank you so much, Yanir, for those great summary words. It's very inspiring to hear that we have many options to keep ourselves safe. We are now going to turn back to our final question and answer session. So I'm going to bring back Maddie and Cecile to join Yanir and with our moderator, Dr. Geraldine Hamilton, to conclude our question and answer session.
All right, thank you very much.
Yeah.
So this first question is for Dr. Haino. What ways can people move towards this transition where we get them to recognize long COVID and that we require action? Are there things that we can do to alter behaviors as individuals or as a society? No, it's a tough question.
Yeah, that's a pretty broad question. Maybe one thing worth mentioning about it is that if we have a huge amount of people, and then if we put out a message and everyone in within that group knows that everyone else has got that message, but if everyone else can also observe that none of the people who have got the message are actually acting according to that message, then we really risk a sort of a backfiring effect in the sense that if you, for example, if there's a mask mandate, and everyone can see that no one is wearing masks, then everyone can look at everyone else and thinking, oh, well, actually, it doesn't seem that much like masks are needed. So another option to doing that, like putting all the awareness in first, is to actually work with smaller communities and businesses and do work within those, like little by little, and this creating the best practices and learning as we go, and like going one network forward every time, and trying to bring forward the larger scale change in that way.
Thank you. Dr. Philippe, if you were a business leader, again, another tough question, you guys get all the tough ones. If you were a business leader, a business owner, or a venture capitalist investor, what would be your main concerns regarding what you've heard here today?
my main concern now would be that I do not want to get COVID. And because actually cognition and cognitive impairment it seems to be one of the big issue, and those people, they work from, or almost essentially from their cognitive abilities to solve very, very fast problem that others are not able to solve. And so I would first take measures in order to protect myself, but because I'm a venture capitalist, I'm looking for the most talented people. And actually, if I strongly believe that they are like an engine within the system, and that actually one of the main issue today is to find those most talented people, and they are few and they are scarce. I do not want the pool to be even scarcer. So I would start trying to think about this long COVID issue, not only in the way that we often hear that we need to accommodate. I think really, I mean, what Yanya said, and is absolutely essential. We at the individual level can take some measures, but some others have to be taken at the societal level. Like quality of air in schools. I did not mention it in my talk, but this is we invest billions of dollars in the education of our kids. Why? Because we think they are the future. They are building the society of the futures. And the huge paradox is that we think that they are not going to be impacted by long COVID, even though they are younger, so they will get infected more often if we do not take any measures. So air quality, masking, if air quality is not good enough. I mean, there are so many things that we can do. And with vaccines together and all the new technologies, I mean, they can really work together so that because one thing is also to preserve our liberties, to preserve what we care, which is actually to be able to interact. That's what I was saying. Interaction are absolutely essential. And if we want to preserve, we need to create those ecosystems where actually we feel safe to interact and we do not contaminate others.
And Yanir, would you like to comment on that question too?
Sure. I think that this idea that people who value their own cognitive abilities should be the ones who are, of course, making sure that they're not infected is clear. But any business owner or leader has to be concerned about the key people that are working in their companies, or, as Cecile mentioned, the people that they would like to hire as the talent to be the engine in their companies. And so taking precautions in a corporate context to protect their most important asset makes sense. People are worried about the structural integrity of their infrastructure, but surely making sure that they're talented workers and everyone's cognitive abilities are important. But of course, there are the diversity of capabilities means that many specific capabilities are important, and that's essential to protect in the context of a modern economic activity, surely very different from our expectations about industrial era production lines, but in the context of the workforce disability that Cecile talked about, it impacts even the production lines and the supply chains at their most basic level, and then definitely it impacts the high cognitive roles that are generally present in today's economy.
Thank you. And I know we're over time, but I have an important question from the audience that I will pose to all three panelists. How can we help kids that are still going to school, wearing their masks, but they might be the only ones in the entire school or in their classroom? Are there any tips to help them cope in that situation and to help them continue to wear their mask successfully?
I think Maddie may have more to add, but I think one of the things is clearly to create the understanding that people should care about each other. And if someone would like to wear a mask, they should be encouraged to wear the mask that they want to wear for their own safety. The first question in terms of social pressure is the acceptance of the right or the freedom of individuals to protect themselves in this kind of a context and to protect their families, their loved ones. So whether children are wearing the mask for themselves or protect their parents or grandparents, or whether parents are wearing masks to protect their children, the siblings, cousins, all of those should be understood as a part of what we do for each other, and an essential part of how we respond to an infectious disease that can cause problems both in the acute phase and, as we've learned today so much, in the long COVID part of the infection.
Yes, I'm going to tell you what we do, because we are a family of 4 and 2 young kids at school, and they wear the mask at all times. And it's not been easy, but the way they are doing it is that they explain to people who ask, because they ask always, and sometimes they are even harassed by some people. And it has worked. It has worked, and especially this year, they are not in trouble anymore. They are telling people, I do that in order to protect my parents. And that, I guess the communication can change, depending on where people are. But right now in France, they are telling something that is true, which is that they are doing and they are protecting their parents. And as parents, we've been speaking to everyone, to the teachers, to the people in all school. We've been going to them. We've been telling them why we do that, and that's how this year they are completely accepted and not putting, in those conflicts where one adult is telling them that they have to take their mask off. So,
any last comment, Matty?
Yeah, my kids are happily not yet school age, so but yeah, I guess an important thing is that as Cecile said, to develop those. I spoke about the relationships and the trusting relationships within your community and with people you don't necessarily see eye to eye on stuff, but it's of course easier to say than actually do. But I think it's super important to actually speak to people and have them understand that your situation may be different from theirs, and you're okay with them doing what their thing, and if they're okay with you doing you. And like something that Janir said made me think of there used to be a time where if you were a woman and you wore pants to school, people were like, hey, why you can't you just wear a dress like everyone else? Why do you need to come to school if you have to wear pants? So I guess it's that much different from that. I don't know. It can't be that much different.
I want to share a great comment from one of our previous speakers, Dr. Duncan. She says that we all parents and all of us who have kids in our families and others should really campaign for leaders to invest in clean air in schools to really protect our children. And that's so important. That's something each and every one of us can do. And I can tell you that even one school can make a difference, because I've done it. So I highly encourage you to do it. And with that, I'm going to hand back over to Katie, who has an incredibly exciting announcement that she's going to lead us into. Don't leave yet, because this is definitely worth staying a few more minutes for. And then I will proceed to our closing remarks.
Thank you so much, Geraldine, and thank you to the panelists for another nice Q&A session. Yes, so we do have an exciting announcement to make. As part of the WHN efforts on long COVID resources at the World Health Network.global, We also have a brand new resource launching today to empower folks in sharing the risks of long COVID with others. For that, I will turn it over to Greg Howard, World Health Network's lead for our long COVID research databank project.
Thanks so much, Katie. We just heard a bit from the panelists during the Q&A about how we can help, not only what we can do to protect ourselves, but what we can do for each other and how we can have a broader impact. While you all have been inspired to join us to learn more, there are many for whom talking about the threat long COVID poses to our long-term health and why COVID precautions remain so important is incredibly difficult. Yet, as Dr. Matti Heino explained to us about the behavioral science, it's really only by sharing what we've learned about long COVID with our friends, our family, our coworkers, that we inspire the changes that can make our communities safer for everyone. To help spark those conversations today, we're also launching longcovidlearning.org, a site that collects scientific research from around the globe and makes it accessible to everyone, even those without any scientific or medical training. Summaries of studies on long COVID are presented as cards that can be easily shared on social media and in private messages, helping to educate others on how the disease is so much more than a little fatigue, and how without stopping infection, we are all at risk. So visit longcovidlearning.org today. Please follow us on social media. We're looking forward to your feedback. More studies are being added all the time, and we invite volunteers of all backgrounds to join the project if you are inspired, as we've been, to help make the science approachable to all. Thank you.
Thank you, and bravo, Greg. This is an incredible initiative. It's going to be such a helpful tool for everybody. And to let you know, please go visit the website, but also that it will continue to grow and we'll continue to add to it. So it will be ever changing and increasing. So check it out. So now for bringing the meeting to a close, it has been an incredible event. It has also highlighted the importance of creating awareness on the long-term impacts and risks of long COVID. We cannot allow people to continue to get infected multiple times with a virus that can severely impact, as we have heard today from our speakers, key organs such as the cardiovascular system, the immunological system, and our neurological system. This virus leads to chronic disease and disability, and acute events like heart attacks, strokes, pulmonary embolism. This is simply not sustainable. These acute events can also lead to disabilities and deaths over the long term. Long COVID impacts the quality of our lives, our ability to work, our ability to innovate, and to problem solve. We must act now to protect our fellow humans, to protect our society and the economy. And there are multiple ways that we can do that. We are not helpless. We need to care for one another. The solutions are in our hands. This is not actually held back by the biology of this disease. It lies in our individual and societal action. We need to adopt the tools and technologies that we have, as well as new ones that will come along to help protect each other and to help those suffering. Thank you.
Thank you so much, Dr. Geraldine Hamilton. Very inspiring words to follow. I have a few closing remarks. We do have some great news that we're going to be hosting more events just like this, but in different languages coming up soon. We're going to be having a German event on September 24th and a Spanish event on September 25th. We're going to be covering the same key topics. We look forward to seeing you at our next WHN events, and I hope that you can join us. Our network is open. We love taking volunteers from all avenues, all walks of life, all spots. So we are welcoming, and you can join us at worldhealthnetwork.global. And thank you everyone so much for being with us today. A big, huge thanks to our speakers, a lot of hard work. I know you're very busy, and we really appreciate your time and coming here. And I really appreciate all of you that have tuned in and that are listening on YouTube. I hope this talk has been helpful and that you can share it with your friends and family to try to get the point across that Long COVID is serious and COVID is definitely not over. So with that, I will bring the meeting to a close and I will see you all soon. Thank you.